Ciao, ciao Bunsang. Hello and very good morning. Uh, My topic, I'm Sabara Faiza Jamaluddin. I'm from the University of Technology Mara from Malaysia. Uh, First of all, I'd like to thank the first Vietnam PATOS Symposium Committee for inviting me to this beautiful city of Ho Chi Minh. It has always been one of my wishes to be in your city, and thank you very much for inviting me. Of course, I will increase your economy of your country by doing a lot of shopping. Um, the trauma burden around the world is very high. However, uh, the deaths from injury is usually more than if you put AIDS, HIV, TB, and malaria together. But the focus on most of countries is to treat the non-communicable diseases and to treat the HIV and other infections rather than to focus on injury. The increase in uh, death from injury was increased if you look into at the 2030, right, the increase in numbers from road traffic accident, from suicide, from homicide will definitely be increased. And we have been seeing this trend for many years. So looking at the traffic situation in your country, in my country, and in especially in the Southeast Asian region, we can expect that a lot of these injuries will increase in the near future, unfortunately. The um, the World Health Organization has said that 5 million deaths occurs from injury worldwide, and making that a leading cause of disability and death especially among the young people. And in our region, especially the Southeast Asian region, the road traffic accident is a significant contributor to the death. WHO estimates that the approximately 30% or 1.3 million people die each year from the result of road traffic accidents, and millions more sustaining non-fatal injuries, many of which are with long-term disability. Whether we like it or not, in our region, most of the regions in Asia, the road traffic accidents are the main cause of injury and death. If you look at this map, it's not very clear, but if you look at the dark colored maps, this shows the percentage of death by injury. And most of the deaths, if you can see, are usually concentrated in Asia, especially in Southeast Asia, unfortunately, for that. And then if you look at the percentage of death in Asia itself, you can see from the list I have made, I put up on the right side of that, our area, Thailand, Vietnam, Malaysia, Indonesia, Philippines, very notorious for having injuries as a high cost of death. If you compare with the world, 8,000 per 100,000 population, and within our region, anything between 9 to 10, so per 100,000 population. So that is very high, unfortunately. And if you look at the mortality, just focus on road traffic accident per 100,000 population, again, right, we see the high mortality of rates from road traffic accidents in our region. And if you look again, if you focus on Asia, right, if you compare with the world, 17 per 100 population is caused by road traffic accident, but from our region, anything between 35 to 20. So a lot of our patients die from road traffic accidents. And when we want to talk about disability or we want to talk about disease burden, we always discuss using the word disability adjusted life years. This is just something of a theory. because mortality does not give a complete picture of the disease borne by any individual. So we just can't take crude death rate. The disability adjusted life year, it is a measure of overall disease burden expressed in the number of years lost due to ill health, disability, or early death. So when we look at the distribution of daily across the population, across your country, across your region, it provides us with the burden of disease. So this burden will represent the gap between the ideal health situation for a population and the population's current health status. It is usually commonly used in global health prioritization. And the main advantage of Delhi is it provides a composite, internally consistent measure of population health, which can be used to evaluate the relative burden of diseases and injuries and compare the population health by geographic region over the time. So when a country describes the burden of disease, or the region describes the burden of disease, they usually use the word disability adjusted life years or Delhi. Now we shall look at what about the Delhi from injury around the world and in Asia. The Delhi from cardiovascular disease and cancers are well known. They do a lot of burden over even in our region and across and all over the world. But if you look at the causes from injury, the unintentional injuries, national disasters, fire, drowning, interpersonal violence, road traffic accidents, all these will add up to 210 million Delhi's lost. And that will be amount to 9.8% of the disease burden of the world. And then that is the third highest. If you add all of it together, it is the third highest after cardiovascular and cancers. Sorry, the arrows have run out a bit different. Okay, so injuries around the world, right? Disease burden, the third most, the highest disease burden, 9.8 cost 9.8%. Around the world, if we look for disease burden per 100,000 from injuries in the world, if you look at the world average, it's about 3,168. And in Thailand, 2004, in Malaysia, 2005, in Vietnam, 3,165. So again, a lot of Delhi, a lot of life, disability life that we have lost. And these are the people during the productive age. This shows the disease burden for injuries in age. If you look at below, the last one, under 5, now that disease burden is mainly due for drowning. And most of the life lost, right, is actually due during the ages of 15 to 49. And that is the time when most of us are being very productive. Vietnam and the area of Southeast Asia and other parts of Asia are highly or a very active developing nations, especially over here in Vietnam. So you do need every single people during the young age and active age to provide and to run to help the economy to develop in your country. However, this is the time between the ages of 15 and 49 that we have the highest burden of injury in the world and even in the region. If we look at the elderly now, more than 70 years old, in the world is about 9.48% of percentage of the whole disease burden. But in some areas of Asia, for example, Korea, Japan, Singapore, Taiwan, Hong Kong, there are more and more elderly patients, right? And when there are more and more elderly patients, they can also get injured. And this will increase the burden of injury to the country. If you compare with the other part of the world, the Western Pacific region, where the Vietnam, Malaysia, Philippines, Korea, Japan, we belong to the Western Pacific area of the WHO with the highest, right, diseases, with the highest elderly, more than 70 years old, that cause the burden of injury, burden of injury, the death from that. So this is something that also the country has to take care of, because when the elderly gets injured, right, they will assume, or they will consume more of your resources as compared to the healthy patients. Having injury and having death from injury is actually not cheap. It's very, very, very expensive. The International Labour Organization, right, says that 4% of the annual GDP, or $2.6 trillion, is lost due to direct and indirect costs of occupational accidents. And here we are just talking about occupational accidents. While in the US in 2019, $4.2 trillion include spending of healthcare, lost work, productivity, as well as estimates of cost for lost quality of life. That's really a huge amount of money that is lost from injury. And then if we look in the ASEAN countries, just due to road traffic accident, it's $15 billion. And if we look at the countries of the Asian Development Bank, which most of the countries in Asia and the Western Pacific belong to, we are talking about 96 billion. So it's a huge, huge burden to the country, not only in the term of disability, life lost, mortality, but also in the cost of the economy to the country. Can we decrease? So what I have shown you is that road injury is a high burden to our nations, to the countries, to the world, and especially to that in Asia. Can we decrease this high burden in Asia? If we need to decrease, we need the commitment from all the stakeholders. And especially these 4 areas. Of course, there are many other areas, but we're looking into the 4 areas of human resource and training, infrastructure, equipment, process and data, and leadership. For the human resource, some of the factors that we can improve upon is standardized courses, having courses like this, teaching our community bystander first aid for the trauma patients, practice evidence-based trauma management, and having a multidisciplinary approach. Trauma does not belong to only one specialty. It belongs to a multidisciplinary specialty that includes surgical, emergency physician, radiology, rehab, across the board of medical disciplines. For infrastructure and equipment, we look into building trauma centers, or more importantly, trauma-capable hospitals that would be cheaper than having trauma centers. Hospitals, better pre-hospital care services, as this PATOS symposium is one of the ways for us to improve the pre-hospital trauma care services. And of course, we don't forget a good rehabilitation, because the patients do need to get well to go back to the society and provide to the economy of the society. When we look at process and data, that is when one of the important facts is that the trauma registry will help looking into the data and also into the process. And in Asia, we have the Pan-Asian Trauma Outcome Study, PATOS, and later on you will listen to more of the talk about registry. Having trauma systems, which is more important, having looking at trauma research, and I think your hospital director mentioned about setting up of a research center in your hospital, and I congratulate you that. And again, having standardized protocols in the pre-hospital care and in the emergency department for managing of the trauma patients. But all this needs the leadership and governments of the person that provides especially the finances. You need also a national trauma policy that governs trauma care from pre-hospital right up to the rehabilitation of this patient. Having a trauma education program, having strong trauma preventive program. Even though there are many motorcycles, many motorcycles on the road, but I saw that every one of them was wearing a helmet. So you do have at least one of good trauma preventing programs. But there should be more of these programs, not only for on the road, at homes, at schools, and having them as trauma prevention programs, having them as a curriculum in school. In my country, we have first aid, we have CPR as a trauma, as a curriculum in school, in the secondary school, in the high school. But it's only on theory. They don't do the practical session. And it's difficult for us to go to the schools and tell that we want to teach you first aid. But we are trying to work better on that. Most of us have a lot of laws to govern the traffic in our countries. Therefore, there must be a good implementation of traffic laws. And of course, a strong leadership overall to look into the trauma situation in the country and to have preventive care. It takes a system to save lives. It's not one person, it's not one hospital, it's not one region, but a system to save lives. And numerous studies have shown that having an efficient trauma system, efficient trauma that encompasses the whole trauma system chain of survival and beyond, decrease the incidence of mortality. And you will have the next session, which will focus on the trauma education and trauma registries and trauma system, and even the trauma quality. If we look into the trauma quality and data, collection of data throughout the whole link of the trauma system, from the time of the incident to the time of recovery and rehabilitation of disability, you can get data from all this, from the phases of injury, prevention, and rehabilitation. And having a good trauma registry, because the trauma registry will look into every phase of this cycle, every phase of this system, where the patient, from the time the patient have the incident, from the prevention to the rehabilitations. And again, for the next couple of lectures, we will have a talk on about the importance of trauma registry and the data that you can get from this. And again, congratulate Vietnam, especially for this hospital, for giving the highest records in the Pan-Asian Trauma Outcome Study. We do not consider trauma as a disease. We consider diabetes, cardiovascular diseases, cancers, right? HIVs, other communicable diseases as a disease. So therefore, because we consider them a disease, we consider them a burden to the country, a lot of the health budget goes to prevention and management of the disease. But because we do not take trauma as disease, and trauma is often called the neglected disease. So therefore, if we do not treat trauma as a disease, we do not consider it as a disease, then probably the government might not focus, might not give the necessary funding to help develop a good trauma care system in the country. So if that happens, unfortunately, if that happens, then trauma will remain a neglected epidemic. So symposiums such as this and across the nation, especially organized by PATOS, help the country and the region to recognize that the trauma is actually something that you really have to take care of. You really have to have a good trauma care system, a good trauma care in your country to decrease the disease burden. So we hope that uh, from my lecture that you have a good, just a bit of idea about the trauma burden around the world and your country. With that, come on.
Thank you for your very interesting lecture from the professors. Yeah, Pat. And next, I would like to invite Dr. Lê Phước Đại come from Chợ Rẫy Hospital. Dr. Rai is the senior emergency doctor. He worked at the emergency medicine department of Chợ Rẫy Hospital for a long time and expert in the emergency care. Today, he will share you the trauma burden and research in Vietnam. Thank you.
Good morning, everybody. So we are starting with the number from Professor Saradia from Malaysia. So I'm a doctor who working day by day in emergency department. I receive more than 100 trauma patients a day. We have more than 50,000 trauma patients a day. So this growing day by day, year by year. So I will speak here with my experience for 16 years working in emergency, and we talk about the burden. We talk about the burden of trauma. That means when you deal with the trauma, it's different from you deal with the internal medicine disease like diabetes or heart disease. The trauma had a special one. They need something like the equip. They need something like the cooperation for many majority or specialty. So I will talk about that. And actually, we don't have much research in Vietnam nowadays for the trauma. The former one, it's just like we have very small research for the year by year, but we don't have anything like official research for everything. But we have the number. We still have a number for the trauma care in Vietnam. So most of all, we consider the burden in Vietnamese were gánh nặng. That means when you deal with that, you feel that it's not good. You feel that it's so heavy. It's so, that if you deal with the trauma, you feel that, oh, it's so dangerous that you don't have enough resources for that. You don't have any blood for that. We don't have any, specialty for dealing with the trauma. So that is a burden. So nowhere like Vietnam. When you travel to Vietnam, especially, then you see that a lot of vehicle in the street, especially motorcycle. So the motorcycle in Vietnam is not, go everywhere. They can go right, they can go left, they can go straight, and they just turn around or you turn very quickly. So the trauma for the road is very, very much in Vietnam, especially when they high speeding or they are wrong. So now we have the rule for no alcohol in the street. So 0 is okay, 0.1 you are fault. So it will make it happen, and the result may be better than that. And before 20 years ago, we don't have helmet on the street, but right now, 20 years after that, we have every vehicle or motorcycle on the street. We must have the helmet on. And the result is when I working in Chari Hospital, the result is better. Less of head trauma with severity. So after that, the result is the death is not high anymore. So just like minor thing, something like that. And for crossing the streets is also dangerous and difficult for pedestrian, especially for us, as for tourists, something like that. So That means you work in the environment are so dangerous of street and vehicle. All right, so we have a highway, but it's not very it's very narrow one. It's not like in USA or in Korea, in something like Japan. It's very very big, but in Vietnam it's so narrow. So if they have an accident, we say the multi-trauma or the multi-vehicle car crash each other, and so dangerous. And we also have a labor accident, but not much. And also the violent too. Here in Vietnam, the gun is obligation. So only knife, something like knife, like Korea, knife, a stick, something like that. They hit each other and it come to the ED. Okay. So why trauma is the burden? All right. Let's talk about the burden trauma care in hospital because I work in hospital for many years. So I think that's why small hospital or the rural one don't care about the trauma care because it costs too much for doing this for carrying the trauma. That's why. That's because of the trauma care. We need the pre-hospital care. We need the stop bleeding care inside the ED. And after that, after doing it, we transfer not, we stay the patient in the hospital and do the good ICU. We have a rehabilitation. We need the disability. We accept the disabilities after the trauma. So talk about it. So rehabilitation care. In Vietnam, we have a transportation. It's different from other country that we use everything we have to carry the patient to the hospital. For example, if you have the ambulance and the relative will help you to put the patient on the ambulance, we have less of the paramedic here. We don't have a paramedic inside the ambulance. So the relative will go with the car, the ambulance to bring the patient to the hospital. Or you can see that the middle, the image in the middle, that we can carry the patient by motorcycle by three, one first for driving, one for the after that for holding the patient. So we in Chile, we see a lot of things of that when everything is so crowded. You have something like everything is just sticky. And so when you go by the car, it's so long to go to the hospital. So they just go into motorcycle and put the patient on it. And we also have the 115 system for pre-hospital care. They have the motorcycle and they can go to the incident place and they carry the patient to the hospital, or they just doing like temporary stop bleeding. Right, the temporary stop bleeding in trauma is so very important because when they bleed so much and they take 20 minutes or 30 minutes to hospital, it's so dangerous. So temporary stop bleeding inside is very important. So you can see the picture that they can do it on site. So right now in Ho Chi Minh City, when you have the accident, you call 115, less than 10 minutes or 20 minutes, they will have the nearest ambulance will come. Otherwise, they have the motorcycle going up. After that, the ambulance come. Okay, and after that, on-site resuscitation. So you see that if the patient needs something like a resuscitation, like trauma, like the C collar, something like that, they can put it on site and transfer to the hospital. So there's still no official training for paramedic. We have the small courses for paramedic in Ho Chi Minh City. It's one from 115 center, and we hire person and train them to be the paramedic. But we don't have the paramedic training system or paramedic faculty, something like that, and pre-hospital care training. So we don't have official, just like something like small one. When you are talking about on the emergency care, all right. So in hospital, the main point of the trauma is stop bleeding. I've learned ATOS in US state. I learned from trauma care around Asia. So the main point is stop bleeding. So we need, if you deal with the trauma, you will need a lot of surgeon. It's just like neurosurgery surgeon. You have the orthopedic, something like abdomen surgeon. So if they have a bleeding, they have unstable, you can do it right away. So the hospital want to do the trauma care, they must have something like a lot of surgeon or the trauma surgeon. It's very interesting that when we're in the United States, it just have a trauma surgeon. They don't have, like something like, especially the big surgeon, especially coming into the ED, but they have a trauma surgeon. That those surgeons do everything about trauma only. They have broken leg or something like that, hematoma, something like bleeding, something like that. The surgeon, trauma surgeon, is doing that. We don't have it here. We just have the specialty. So if they have something like broken leg, we invite the orthopedic doctor come and they have operation. And again, we need the operation room, the OR ready. It's so important because when you're ready for the OR, if you have something like, if you have a trauma, you have a fast scan, if they're positive, they bleeding a lot, then they put into the OR very quickly, and the OR must be ready. For example, in my hospital, in my ED, we have the OR inside the emergency department. So if you have a chest stop, something like the chest stop into the heart, it's a 5 minutes to open the heart. So it's just so important to save the patient. All right, or the trauma operation room or general operation room. So depend on the hospital, they can dividing or they can supporting the room or the OR room. So that's the big deal with a small hospital that they don't have enough OR for that. And after that, when you deal with the trauma, the blood is so important because when you have a bleeding so much, we have a massive transfusion protocol 111. And in Chile, in the big capital, we have a blood bank inside Chile. So we have a blood very fast, maybe 10 minutes or 20 minutes. I heard my colleagues from all the hospital that they make something an hour or hour, 2 hours to have a blood into the emergency department. It's not good at all for trauma care. And after that, we need the trauma station. The trauma station, that means the separate space for trauma. When you go to the emergency, when you have a separate place for trauma, you have an ultrasound, bedside ultrasound, you have an X-ray, bedside X-ray, or the clear way to X-ray area. That means it's very clear. And close CT scan, so CT scan is very close to ED so that you can do the MSCT scan for multi-trauma patient. And we need to train the equipe for trauma. So when you have a trauma station, you have a doctor, you have a nurses, and you have a helper for trauma. It's just like ATOS, we have a controller for emergency doctor and specialists are around. And maybe the nurse will know what they will do. So just like the very last of IV or CVC or something like that, ultrasound, they will help you to do it very fast. And the time for resuscitation is going down and the chance for the patient's life is going higher and they will do it very fast. So for example, in my ED, when the trauma comes, it's very easy to have an ultrasound very quickly. It's just 2 or 3 seconds. After that, the IV, the nurse will doing it very fast. If the nurse cannot do the IV, we do the central line or the CVC is very, very quickly. After that, you have a good IV. You can give blood, you can give medicine, you can give the fluid very quickly. And we talk about the vascular intervention and interventional radiology. So luckily in Chile, in some big hospital, we have the intervention radiology for the bleeding. It's just like the liver or spleen. When you're bleeding, maybe they don't need to operation anymore. They just do the interventional radiology. And for the fracture of the femur like that, maybe the intervention radiology will have. They don't need to operation anymore. So the answer is just do it, block it, block the artery, and everything we control. All right, so after that, we transfer or not in Vietnam or in Ho Chi Minh City, you can use the ambulance or you can use the helicopter. But the helicopter belonging to the military, so it's hard to use helicopter here. But if there's something happen, you can know that Ho Chi Minh City have the helicopter for transfer. They transfer to a higher hospital. They transfer to another country or something like that. Then we have a helicopter here, and we have the good ICU. That means after you have deal with the bleeding, you need to put them to the ICU to that so that after that they can recovery. And rehabilitation is very important for the trauma patient and also the disability after the trauma. So it takes a lot of resources to establish and maintain the trauma care. That's why it's the burden. So we don't have enough money here. We are Vietnam. We don't have enough money. Just don't like Korea or United States. So right. We have a lot of resources, but we don't have it. So uh, trauma is still burden in Vietnam. All right. So they have some number. We have a number from the Ministry of Health. We have a RTI, road traffic injury, about 15,000 death case a year. It's too much, right? Account for 44% of trauma-related death. That's in 17.08 per 100,000 population. And the 20 to 59 years old is 72.3%. The rolling exercise and labor accident is, it's not much, but the road traffic injury is the best, is the most injured in Vietnam. I think in Malaysia, I think in Southeast Asia, it's the same thing because we ride motorcycle too much. And when I give you the number of Charai Hospital, we consider to be a level 1 trauma center because we have a lot, we have the standard for everything for trauma. Right, so in my emergency, we receive more than 120,000 patients a year. So a day we have more than 300 patients a day. And 38%, this is the number from emergency department where I work. About 45 for 600 patients can with trauma. It's a lot. We do a lot of trauma in my ED. So 65% were transferred from provincial hospital and 35% come by themselves. Because that's something like if or the transfer with the paper. In Vietnam, sometimes they transfer the patient without paper, without notice, or without sending information, because the trauma patient or relative is so nervous. They're so aware of if they stay in the province hospital, they stay in the rural one, they will die. So they just take the ambulance going, and they don't care about the paper. Okay, we're okay with that. It's okay. Just come and we treat. It's okay. So the number is so high, 35% of common themselves, but really come themselves. That means when you have a stop in the street, something like that, it's so minor. It's so minor. But if you go like that, they don't believe with the rural one. They just go themselves to Chaurai. It's a lot. Right, the tumor case about 76.1% in my ED. And the something is the majority 20 and 59-year-old group. So why Chaurai receive too many cases? So we consider to be a level 1 trauma center. We have a good session in many specialty. We have a OR, we have a lot of OR ready. We have one OR in emergency too, and we have blood bank. If they have something problem, we have a blood bank. So they have a lot of blood coming very quickly. And we have a trauma station. We have intervention radiology, and we have a good ICU. So Chile is the considered to be the first the level 1 trauma center. So, but in Vietnam, we don't have too many level 1 trauma center. You look at the map of the Vietnam, you see that in the north, you see that the Hanoi, in the middle, you hear Da Nang, and in the south Vietnam, Ho Chi Minh City and Cang Tho. So if the patient is live in middle of the big city, they will transfer by ambulance. They will transfer by ambulance. If they live in the island like Paracel Island, or Spratly Island, or Full Island, maybe they go by the helicopter. So we just build for the big city for the level 1 trauma center only. So is it the burden for trauma care in Vietnam? All right, so rehabilitation and disabilities, this is the numbers of daily. So we have a lot of, injury and disability. Thank you. Uh, it's okay, right? It's not sleepy, right? Everything interesting. That we deal with trauma year by year, day by day. And when I sit here, maybe a lot of trauma were treated in my hospital. And a lot of people are healing and treat very well. Most of the doctor in my emergency can use ultrasound. They can use something like do a CVC very quickly. And we have a protocol for police trauma too. So thank you so much.
Okay, thank you for your nice presentation. Let me invite the next speaker. The next speaker is Dr. Tae-han Kim. He is working as a clinical associate professor in Seoul National University Borabe Medical Center. He is emergency physician and medical director in Seoul Metropolitan Fire Department. He will present about trauma registry in Asia and the world.
Okay. Good morning. My name is Tae-han Kim. I'm from South Korea. I'm an emergency physician and also working as a medical director for the Seoul EMS system. Thank you for the invitation today. It's my honor to be here to present the trauma registry of Asia and the world. Thank you again for the invitation to this great conference. So today I will talk about the trauma registries of the Asia and the world. Collecting the patient data through a registry is a very unique and important for the certain disease entities, such as especially for the severe injured and severe diseases such as cardiac arrest and major trauma. Because it is from the standard data collection and data analysis is the first step for the trauma care system improvement. With the standard data collection and the analysis result, we can evaluate and assess the current system of the trauma care. And after the assessment, we can identify the current system's problem based on the analysis result. And not also the analysis, after identifying the problem, we can suggest some plans and solution to solve the problem. And after that, if we implement and give action of these plans, then we can evaluate the effectiveness of the intervention and solution with the same registry. So the importance of trauma registry is very important. Today, I will talk about some trauma registries around the world, about 5 registries. First will be the National Trauma Data Bank of the United States. And second, the National Electronic Injury Surveillance System, also from the United States. And thirdly, the Trauma Audit and Research Network, which is called TAN from United Kingdom. And fourth is from the Japan Trauma Data Bank. And finally, I would like to give some introduction of the PATOS. Since this is a PATOS symposium, I will spend some few minutes introducing to you about the PATOS network. The National Trauma Data Bank is maintained by the American College of Surgeons in United States. This is the largest trauma registry of the United States. The data of the trauma patients are submitted from more than 700 hospitals, and the enrollment criteria is according to the diagnosis code, which is IC10-CM currently. The data are coming from the various levels of the trauma care centers. From the level 1, which is the highest trauma center, it's about 31% of the data is coming from the level 1 trauma center, but also from level 2 and level 3 and 4 centers, which will be about more than 50%. And some of the data are coming from the level 1 or level 2 pediatric only centers. So the most of the data is coming from the higher level of the trauma center, but also coming from the lower trauma level center from the communities. This is the map from the NTDB annual report. You can see the map of the United States. And this is the largest trauma-related database in the United States. So all over the nation, more than the red color is the participation rate is more than 67%. So all across the country, more in a lot of states, more than 67% of the trauma patient data is submitted to the NTDB. But still, in some of the states, the participation rate is still low. The weakness of the NTDB is they rely on the voluntary participation of the data input. This is not an obligatory thing. Although it's the largest database of the United States, it relies on each hospital's voluntary action. So some of the data has a slow input timeline, and also some of the data's accuracy is a little bit low. And also, as you've seen in the slide before, in some of the region, the lack of representativeness in local level was shown. So although we had a certain weakness, NTDB is the largest network of the trauma registry currently operated in United States. The second will be the National Electronic Injury Surveillance System. With this system of registry is operated by the U.S. Customer Product Safety Commission. It started in 1970s, and data are coming from from 100 sampled emergency department, from representing more than 5,000 hospitals in United States. The aim and the target is a little bit different from the NTDB. This NEIAS target is to monitor the product safety and identifying the potential hazard, such as everyday product they would use, such as a cooking machine or some kind of sports activities and some everyday stuff. So the monitoring of consumer product related injury is very important for this trauma registry, and to inform the regulatory action and also product recalls and public safety initiative is very important intervention from this database. So using this database, it is a trauma registry, but I think this is a little bit of a surveillance network over everyday product, and it monitors the safety level and also the safety accidents of the everyday products, such as the pressure cooker. I'm not sure that in Vietnam, we use the pressure cooker a lot, but in Korea, we use a lot of pressure cooker to cook the rice and chicken and everything. So, but this is sometimes very dangerous. So, but with the database, they could understand the actual rate of injuries and the severity of the injury using this pressure cooker. And also they also monitor some newer technology and newer customer products, such as the hoverboard. This is a newer technology that you can see nowadays. The young people use this as a transport, and they also collect the data of the safety and also injuries caused by the hoverboard and report to the public and use this data to make a recall intervention and also some safety interventions of the communities. Recently, the NEIS is expanding their scope to the all injury program. So this is a NEIS AIP's expanded version of the NEIS program. They collect all types of injury, and also they used interagency agreement with the United States Center for Disease Control to collect all types of injury database, and they combine their database to analyze the all types of injury results. The weakness of NEIS is also there is the sampled data. It's very scientific and statistically sampled, but it's not all data of the injury patient, but just the sample data is strength and also the weakness. And also it is a strength, but they always focus on the injury cause and circumstances rather than the treatment in the hospital and also the result of the treatment that with the injury. So because they are like kind of surveillance system of the safety of the product, they focus more on how the injury happened and what caused the injury rather than how they are treated and what's the outcome of the injury treatment. And they also focus on certain populations such as pediatrics and some intoxicated patients. Next, we will move on to the TAN, Trauma Audit and Research Network. It is operated in United Kingdom. It was established in 1989. The aim of the TAN is for the improvement of general trauma care. So you usually evaluate the system. The normal criteria of TAN is the major trauma or injury patient with a separate criteria with one of them admitted to hospital for more than 72 hours, 3 days, and admitted to critical care unit, or a patient who died in hospital, or a patient who are transferred to another hospital to specialist care. So primarily they enroll the severe and major trauma patient with a certain level of length of stay in the hospital or certain level of injury. So they have a lot of publication based on TAN data set. It's a very good database, and they all have a lot of research product according to about the injury epidemiology and also for the treatment outcome that was done in the hospital level. And they have a very detailed data about the anatomic site of the injury from head, face, thoracic, and abdomen, and spine, pelvic, and also the extremities. Another unique thing about TAN is that they always use their data to evaluate their system and also research purposes, but also they use this data as a quality assessment of the in-hospital trauma care of each institute. And this data is the baseline, used as the baseline data set for the payments incentive system, which is called best practice tariff that was chosen by the National Healthcare Service in United Kingdom. I think this is one of the reasons that the data input from each hospital and also for process audit is very accurate and well their quality is well controlled. But the weakness of TAN is that they have a very long time lag and the resource consuming is very high. In the process of the trauma audit, they have to input a lot of data set, and they need a lot of manpower and also other resources. The fourth data set registry is the Japan Trauma Bank, which is JTDB. This is similar to the National Trauma Data Bank in the United States. It's operated in Japan. It was initiated in 2003 by Japan Association for Surgery of Trauma and also Japanese Association for Acute Medicine. The 2020 report showed that it has 288 participating hospitals, which are acute critical care and trauma centers. The aim and the target of JTDB is the nationwide coverage of the trauma patient data. So initial enrollment criteria is AIS-3 or higher, which is moderate severity of a trauma patient, but all trauma patients can be registered to this system on discrepancy of the each hospital. And the unique thing of the JTDB is data include the pre-hospital stage of the trauma care, which is very similar to Korea. So after they collect the data, they make this report every year, and the recent report is about recent report was published in 2022 with the data of 2019 to 2021. It's published by the Japan Association of Surgery of Trauma. In this report, you can see that they have data from various regions of the Japan hospitals all around the country. So if you represent the national level of trauma incidence and trauma care, and also the pre-hospital information is covered here. And they have a report of the outcome, also outcome according to the mechanism of injury. So for instance, they have a lot of motor vehicle crash. It has about 10% of the 10% of death rate, and also very high death rate of the train incidents. And also they have a lot these outcomes according to the all types of mechanism of injury, and they can look into their trauma system and how their trauma patients are happening in their communities. The weakness of the JTDB is similar to the previous database of the voluntary network, which also voluntary participation and data collection is voluntarily done via internet access. So the completeness and the accuracy has a little lower level, but they are using their quality assurance program to improve this problem. And also the time lag is a little problem in this voluntary network. So we looked into the 4 overseas trauma registry. And finally, I would little bit talk about this PATOS network. The PATOS stands for the Pan-Asian Trauma Outcome Study. This is the multi-center registry of injury patients in Asia and Pacific region. The trauma patient was transported via EMS ambulance or other transportation is the initial enrollment criteria for this trauma patient. So it was initiated in 2013, and after the preparation, the PATOS phase 1 started at 2015, and in 4 years, we have collected about 70,000 patient data from the PATOS network. From 2018 December, the PATOS phase 2 started until 2020 December. We also collected patient data more than 50,000 data, and now is PATOS phase 3. So it is under the Asian Association of EMS, Emergency Medical Service. We have an executive committee, and also the coordinating center has 3 committees of data quality management, education and training, and research designing and support committee. And also publication committee has a 5 publication committee of each subject. More than 10 countries of Asian Pacific are participating in this PATOS network. And as Dr. Shin introduced, Vietnam has a very high role of a high number of registering data in PATOS network. I appreciate that this hard work from Vietnam, colleagues of Vietnam. Thank you very much. We have PATOS variables are consisted of 5 categories: demographic and injury epidemiology, pre-hospital care, inter-hospital transfer, and emergency department and hospital care, and finally the outcome. So we have detailed variables according to these 5 categories. And we have an internet-based collection system. We don't use the paper or to collect this patient data. In every site, they can log in with their ID and put their data with the internet. And not only the collecting data and use it as a generate paper, we also gather together to research workshop for discussion of better trauma care or research subject. Even during the COVID period, we had a research workshop. And also we use this network to, like this symposium and today and the workshop tomorrow, we use this network to train the hospital care and EMS care providers to train them, such as TBI symposium and also this kind of a research symposium. The last symposium was performed in Thailand in November. This is the final slide of my presentation. So to summarize the trauma registry, there are certain points, important points for trauma registry that you should choose, and you should characterize your trauma registry. You should choose the primary target population. It will be all trauma or major, only the severe trauma, or like NEISS, maybe the trauma related to certain issues or population of intoxication, customer product, or pediatric. Maybe some of them old age patient. And also you should decide which stage of the trauma care you should include. Would it include the pre-hospital stage of walk-in, ground ambulance, air ambulance, or it will just cover the in-hospital or inter-hospital stage of the trauma care? With that decision, you should choose how to gather the participation hospital. It would be either voluntary participation, because with the less funding source and motivation, but it would be better if you have obligatory participation, but there should be legal basis of participation and also reimbursement strategy to reimburse each hospital. And also one of the good idea will be the linking with another national database, such as CDC database. And also data collection and quality control will be very important. So recent days, most of the trauma registry are collecting their data through the internet, and also quality control method, cycle, and how they make the committee will be very important for the quality control of the trauma registry. And finally, the utilization of collection data will be assessed. Of course, it will be used as the trauma care quality assessment, and also it should be used as a developing strategy plan for the communities, and also it should be used as good research purposes. This is my last of my slide. Thank you very much for your attention.
Okay, thank you for a nice presentation. Now we have some discussion session. So do you have any question or comment on the floor? No question? Okay, I have only one question for Professor Kim. So Sabaria and Dr. Lu present about some difference of specific trauma care system or injury epidemiology in Vietnam and Asian countries. So how can you reflect this difference to trauma registry well for research or any policy development?
Thank you for the question. I think I'm not very familiar with the trauma care system of Vietnam, but as I heard from the previous presentation, I think it will be very important to start a trauma registry that could really actually see the trauma incidence and epidemiology of the Vietnam. I'm worried that they have not structured data processing program yet, but I think using one of your national data such as the national death certification data, which Dr. previously mentioned, and using that kind of surrogate database and to look at into the trauma system is very important I think in this stage. Thank you.
Okay, thank you. Okay, we already passed this section time. Thank you very much for nice presentation, three speakers, and thank you for attention of our audiences. Thank you very much.
And before the end of the first session, I would like to invite the speaker on the stage to give the certificate. Yeah.
Yes, please welcome to the stage, Dr. Sabaria Faisal. To the section 2, concept of trauma care system development. Trước khi mình bước tới cái section thứ hai thì chúng ta sẽ có 20 phút giải lao. Thì các anh chị có thể giải lao, chúng ta sẽ quay lại vào lúc 10 giờ 50 phút để bắt đầu cái session tiếp theo. Xin cảm ơn các anh chị. Mời các anh chị chúng ta quay lại hội trường. Phiên tiếp theo chúng ta sẽ chuẩn bị bắt đầu. Please come back to the hall. We are prepared to start the next section.
Các toàn thể quý vị đại biểu chúng ta vào để chuẩn bị cho cái phần thứ hai. Session 2, Concept of Trauma Care System Development. I would like to Dr. Ivan Chu present the trauma care protocol EMS and hospital. Ivan. Mấy em mời Dr. Ivan Chu vô chưa ạ? Thì cũng báo cáo sơ với lại tất cả các quý hội viên, đó là Dr. Ivan Chun là một cái consultant ở Department of Emergency Medicine at Singapore General Hospital, thì làm từ năm 2008 ha. Thì đã có rất là nhiều kinh nghiệm về triển khai trong cái hệ thống cấp cứu. Không biết. Yes. Không biết là có không, đâu mất chưa đây. Yes. Bảo Huy ơi, em mời các cái báo cáo viên họ vô đi em, đâu mất tiêu trơn rồi. Bảo Huy ơi. Dr. Huy. Giờ này mới lên. Dr. Huy ơi, mời các cái báo cáo viên họ vô đi em.
Xin chào. Good morning, everyone. Okay, hope everyone had a good break. My name is Ivan, and I'm an emergency physician in Singapore General Hospital. So here I'll be talking about trauma care protocol in emergency medical services and in the hospital. Just a financial disclosure. Thanks to the organizing committee for bringing me here, and thanks to Zoe for sponsoring this trip as well. All right, so I think when we talk about trauma, I think it's important to talk about the concept of the golden hour. So this term was actually coined by a trauma surgeon, Dr. Crowley, who is actually the founder of Baltimore's Trauma Institute. So this was actually in an article that he wrote in 1975. This was actually before the time of Advanced Trauma Life Support, or ATLS. So he actually coined this term, the golden hour, as a time whereby what you do actually has an important effect on a critically injured trauma patient. So advanced trauma life support is something that a lot of emergency physicians, as well as trauma and general surgeons, or even orthopedic surgeons undergo. So this course was actually created by this orthopedic surgeon, Dr. James Steiner. So he was a pilot as well, and he actually flew his own plane in 1976. And unfortunately, he had an accident, crashed into the field in Nebraska in the United States. His wife was killed immediately, and 3 out of his 4 children were critically injured. He managed to flag down a car to bring him to the nearest hospital, but it was closed. So when the hospital opened, because they had a break, and it brought in a doctor, he found that the emergency care that was provided in a small hospital that we were treated in was inadequate and inappropriate. It was as if the doctors did not know what to do. So he called a friend, and his friend brought him and his family members to Lincoln General Hospital in a helicopter. So 2 years later, he designed the course, the Advanced Trauma Life Support, and since then, it has become the standard for trauma care in the emergency department and in emergency medical services. The latest edition is the 10th edition, which was released in 2018. So when we talk about emergency medical services, I think it's important to recognize that there are actually two different models that is actually used in the world, the Franco-German model and the Anglo-American model. So for the Franco-German model, there's actually a doctor together with a paramedic in the ambulance. As a result of that, they bring the hospital to the patient. They are able to treat patients with more skill sets. And of course, what they can do is sometimes stabilize and treat the patient, and they may not even end up going to the hospital. But if they do need to go to the hospital because the doctor has already been on the scene and assessed the patient, then what they can do is actually directly bypass the emergency department, saving the emergency department some resources, and actually send the patient to the ward. So for instance, if I have a stroke, they can send the patient to a stroke unit, or if the patient has ST elevation MI or STEMI, the patient can be sent to the cath lab immediately. For the Anglo-American model, this is usually run by paramedics, and the paramedics usually have some kind of a medical oversight. So what this means is that the paramedics, they actually have certain protocols that they have to follow. But if let's say there's any issues that they want to ask, they can actually check with a medical director. And because of this, most of these patients do end up getting to the hospital, and these patients will end up getting treated and being discharged there. So when we talk about emergency medical services as well, it is important to note that there are different types of transport services available. So what you can see here is we have land transport, which is using the ambulance. We have air transport as well, which is using the helicopter. Certain countries, they may even have a water evacuation transport as well. So when to use this kind of transport services really depends on the kind of setup that you have. For instance, in the UK, they choose to use the helicopter because it is actually much faster, and for them to drive on the roads are very narrow, and so it may take patients maybe 40 minutes to get from point A to point B, whereas if they fly, it may just take 10 minutes. So I had the opportunity to do a trauma fellowship in the Royal London Hospital, which is a level 1 trauma center, and they see a lot of major trauma cases. So sometimes these major trauma patients are brought in by the helicopter because it is actually shorter and quicker to bring in by the helicopter. So what we can see over here, the lady on my left, she's actually my supervisor when I was there. So she's an emergency physician by training, and she's the trauma director of the hospital. And on to my right, we have a critical care paramedic. So the critical care paramedic is actually a very highly ranked paramedic in the United Kingdom. So the critical care paramedic has to undergo a master's program and has to undergo some kind of accreditation. And this paramedics can actually do things like intubation. They can help the doctor with things like thoracostomies or even ED thoracotomy. So for the London HEM service, which is the helicopter emergency medical service, the doctor and the paramedic will go out into the field if they have a call for a patient who is very sick. So if the patient has been stabbed and is critically injured, then they may go down to the scene. They will assess the patient. They will set IV lines, give medication, give blood products. And if the patient has a deterioration along the way, and if they need to do any kinds of intervention, then the doctor may actually do things like resuscitative or emergency department thoracotomy on the site. So as you can see in the photo on the right side, this is actually the back of the helicopter. So it is actually quite narrow. The patient is just sitting in front of me. And then we have another 2 seats on my right side. So it only allows 3 people to sit inside the helicopter. And for the helicopter itself, there are 2 pilots, and they'll take turns to, of course, navigate and make sure that the helicopter lands safely. So for the United Kingdom, I think they have a very good safety record in terms of all these helicopter emergency medical services. And of course, they also have certain guidelines, such as only using the helicopter in daylight hours. So for winter, for them, because the winter time, the daylight hours are actually much shorter. Sun may rise at 8 a.m. and sun may set at 3:30 p.m. So they have a shorter working period as compared to summer, when the sun may rise at 4 a.m. and set at 8 or 9 p.m. So when we talk about trauma, it's important to know what is the major cause of death in trauma. So this was actually described in 1983, the trimodal distribution of death. So what you can see over here is there are 3 distinct peaks of deaths. For the first one, 50% of trauma patients will die very soon after the injury. And these are usually unsalvageable due to the cause, which is usually things like major bleeding from blood vessels like the aorta, or it can be due to severe brain or high cervical spine injury. For the next peak that you see, 30% of the patients die minutes to hours after that. So this is actually the critical period, which is the golden hour period. And what we can do during this time may actually help to save these patients. So as you can see here, 40% of them actually die because of airway issues, 25% die because of blood loss. So for paramedics and doctors, this can actually be potentially life-saving when you intubate them or you put them on LMA and give blood products or even give fluids to bring up the blood pressure. For the third peak, this 20% of patients will still die after major trauma. And this is usually hours to days to weeks after that. And this is usually due to the complications of trauma. For instance, a severe systemic inflammatory response syndrome, or due to ventilator-associated pneumonia in the ICU. So this is actually a more recent article that was published in 2019, which helps to explain why trauma patients die. So what you can see over here, it is quite similar. For the first 2 parts within the emergency department and pre-hospital, as well as within the first 24 hours, we can see that major hemorrhage as well as traumatic brain injury, or TBI, are the main causes of death in these patients. So it is hence important that we recognize that the C, which is a catastrophic bleeding, is of utmost importance, and we need to do what we can in the pre-hospital setting to try to save these patients. And of course, after that, we see the other tenets of advanced trauma life support, which is your airway, breathing, circulation, and disability. So for C, it is quite important to think of what we can do upfront to stop the bleeding. So for instance, we actually have a tourniquet that can be used to avoid bleeding from the limbs, upper or lower limbs. If you have a major bleeding from a chest wound or the abdomen, then we may need to apply direct pressure because it's impossible to use things like tourniquet over there. The next is, of course, to try to bring up the blood pressure as far as we can. Ideally, blood is the best product that we can use for resuscitation in trauma, but we know that blood products are quite limited and it can be quite difficult to transport en route in the ambulance because, you know, the weather is very hot. You need to have things like proper storage facilities like refrigerator, etc. So it is quite difficult. So the next alternative may be to use things like fluids. So if the patient is hypotensive, then we may consider giving crystalloids like normal saline. And next, I also talk about tranexamic acid subsequently. So in the United States, in the state of California, in 2022, they actually passed this bill, which is to stop the bleed. So in the US, they actually have a lot of penetrating trauma, things like gunshot wound. In the UK, they have a lot of stabbings. So a lot of patients, especially the young ones, they die because of all this bleeding, which is potentially salvageable if we do something quite early on. So because of that, they passed this bill and they legislated that, in the new buildings throughout the state, they need to have this kit, which is to stop the bleed kit. So this is actually, you can see over here on the bottom. It's a commercial kit that costs US $63, but of course you can actually create your own kit with things like gauze, saline, gloves, trauma scissors, and a tourniquet. And they have a lot of all these posters that have been designed to tell people what to do in the event of such a catastrophe. So as we can see over here, there are also a lot of articles that actually have shown that use of a tourniquet in a pre-hospital setting, especially for penetrating limb injuries, actually help these patients. So these patients who actually have tourniquet, they actually require less blood transfusion because there's less blood loss in the field. And these patients did not have additional complications like nerve palsies or even secondary infections. So the study on the right is a study from Sierra Leone in Africa. So they actually trained a group of student nurses, and after that they follow up with what they did. And it seems like 75% of people who actually attended the course had one encounter with a bleeding patient after 1 month. And this increased to 98% at 12 months. So the incidence of such penetrating trauma is actually quite high over there. And as you can see, about 1/3 of them, they actually have injury on the limbs, in the lower limbs. And the respondents actually intervened in 99% of such cases. And the 97% of these patients actually do survive. So when we have paramedics out in the field, it is important that we have some kind of a protocol for them. So this is actually a protocol that we have in Singapore for our paramedics. So it teaches them what to do, what kind of cases are considered as major trauma. So they will need to do the ATLS principles and follow the spinal immobilization if necessary, maintain a patent airway, giving oxygen as necessary, and achieving hemorrhage control. And if patients have significant injuries, which are defined on the right side, such as penetrating trauma, 2 or more long bone deformities, pelvic fractures, etc., then all these cases may need to be transferred to a hospital that is capable of treating them. So this may need to be like a trauma unit or even a trauma center, depending on the setup. And of course, if the patient is unstable with hypotension, low GCS, hypoxic, then we need to stand by the hospital so that the hospital is aware that such a sick case is coming and they can actually prepare what they need to do beforehand. So when we have a trauma standby, then the hospital can decide if they want to have a trauma team activation. So what the trauma team activation means is that we get a whole team of doctors and nurses and other allied health staff in early so that we can preemptively decide whether the patient needs to undergo certain kind of imaging or resuscitation and try to coordinate all this so that we can save time when the patient comes. So we can see over here, this was a photo taken in the Royal London Hospital. The lady with the computer, she is a scribe. So when the patient comes in, she'll type on the computer the details of the patient, what time anything was done, like IV fluids or IV tranexamic acid or any blood products that was given. The lady in the center with the stethoscope, she is a trauma leader. She's a registrar. Sometimes you can have a trauma leader as the ED consultant or the ED registrar. And of course, the lady with a scrub cap at the head of the patient, she's actually an anesthetist, so she'll help out with things like intubation and airway support. And of course, the other people around wearing the lead shoes, these are other team members. They may be orthopedic or general surgical residents who will help out with the assessment of the patient. So depending on the setup, there are different kinds of trauma team activation. It can be a single tier, it can be 2-tier, or it can be 3 or more tiers, depending on where you are. Sorry. So I'll talk about the 2-tier trauma team activation system first. So as you can see on the left-hand side, this is actually from a UK publication. So they have a simpler trauma team activation if the patient has a significant mechanism of injury, but a normal physiology and anatomy. So this trauma team will just comprise of a senior doctor from the ED, a junior doctor from the ED, an ED nurse or two, a scribe, and a radiographer. But if they notice that the patient has an abnormal physiology or anatomy, such as things like low blood pressure, tachycardia, head injury with low GCS, then they may choose to actually activate a hospital trauma team. And this will include the previous group of people with additional input from the surgical registrar, the intensive care registrar, and the orthopedic registrar. And of course, they will get other people in as well, such as the porter, the OT, as well as the blood bank ready in case the patient needs blood products and need to go to the operating theater. There's also a single tier trauma activation system for smaller centers and for centers that do not have all the necessary manpower. So there is always a trauma team leader. It can be an emergency physician, a trauma surgeon, or even an anesthetist, depending on where you work. And the trauma team leader will be the one who will be coordinating the resuscitation of this trauma patient. And usually we'll have a junior ED doctor and a trauma nurse who will help out with setting lines, giving medication and blood products. There's a surgical resident as well who may help in putting in chest tubes. And the orthopedic resident usually will help out with things like a secondary survey. So for trauma, usually is a standard template, standard workflow that people will adopt. So there will be a primary survey that is performed, making sure that the CABC is all done. And then after that, there will be a secondary survey. And usually 24 hours later, there will be a tertiary survey that's performed. So the purpose of all this is to make sure that we don't miss any injuries, because any injuries that is missed can potentially be debilitating for the patient. So as we can see over here, the criteria for trauma team activation really depends on where you practice. But broadly speaking, it can be divided into three broad categories, which is the mechanism of injury. For instance, a fall from height more than 6 meters, when you're flung from a motorcycle that's traveling at high speed, maybe 60 kilometers per hour or more, a prolonged extrication time. We have the physiological factors, which can be things like low GCS, low blood pressure, hypoxia, or it can be things like anatomical injuries. So penetrating injuries to the chest, 2 or more limb fractures, flail chest, for instance. So in trauma, it is important to avoid the lethal triad, which is coagulopathy, acidosis, and hypothermia. And so when the patient comes in, it is important to actually assess the patient quickly and then put on dressing for the patient, cover the patient up, and give blood products or medication that can help. So one of these drugs that is actually proven to be very useful in a trauma setting is tranexamic acid. So the blood will clot and the blood will lie by the body because of all these various things that's happening. But the tranexamic acid actually helps in bleeding patients by blocking the conversion of plasminogen to plasmin and prevents the blood from actually the blood clot from breaking down. So this is actually the reverse of conditions like stroke or acute myocardial infarction when you give things like tissue plasminogen activator or RTPA. So the results of tranexamic acid actually came from this trial called the CRASH-2 trial. It is a multi-center trial done in 40 centers, 40 countries, and they look at 20,000 patients from the trauma setting, and they assigned them to either tranexamic acid or a placebo within 8 hours of injury. And the primary outcome that they looked at was death in the hospital within 4 weeks of the injury. So from the result of this study, we know that for bleeding, it helps to reduce bleeding as well as mortality rate. And the earlier we give it, the better the results will be. So in most centers, we do want to give it within 3 hours of injury based on the results of this study. So when we have a very sick patient, sometimes we need to think whether we need to give emergency blood products. And if we need to give a lot of emergency blood products, there may be a need to actually give other things as well. So we are talking about the massive transfusion protocol, or the MTP. So the definition of MTP is more than 10 units in 24 hours. But of course, sometimes we may need to actually activate this protocol much earlier on, because we can't activate it, after the patient is in for 24 hours without doing anything. So some centers, they will use the definition of more than 5 units within an hour. And this is usually in the ratio of 1:1:1 for blood products, platelets, as well as fresh frozen plasma. And there are various scores that can be used, but the one that is more commonly used is called the ABC score, which is assessment of blood consumption of products. So less than 2, we will suggest the unlikely need for MTP. So we take it as a 2 or more. So if the patient has a low blood pressure or is tachycardic with a heart rate of more than 120, then it may be appropriate to activate the massive transfusion protocol. FAST is a focused assessment using sonography for trauma. So we are looking at free fluid in the abdomen after trauma. And of course, if the patient has a penetrating torso injury, is also a higher risk of bleeding, and blood products will usually be necessary. So this is actually one part of the damage control resuscitation that is done in the hospital. So the other principles of damage control resuscitation will be things like a permissive hypotension. So we do not want the blood pressure to be too high for certain trauma patients. Patients who have too high blood pressure may actually not be very good, because you can actually help to destabilize the blood clots and cause more bleeding. So for permissive hypotension, we are referring to blood pressure maybe about systolic 65, MAP of 65, or systolic blood pressure of about 90 and below, if the patient doesn't have any contraindications. So we're talking about things like brain injury, or pregnant or elderly patients. So all those, we should follow the normal convention of resuscitation. So once we have done all this for the patient, at the end of the day, the patient needs to go somewhere. So they either go to the operating theater for damage control surgery, or they may end up in the ICU if they do not need any surgical intervention. So the kind of surgery that they undergo is actually an abbreviated surgery, which is actually just to restore the physiology, but not to restore the anatomy. So what this means is that they will actually maybe undergo packing of the abdomen. The abdomen may not be closed. It may be left open, and the relook laparotomy may be done 24 hours later when the patient is more stable. So this is actually help to prevent the patient from deteriorating in the ICU and OT, and allow the patient some time to recover before definitive surgery is done, or even a transfer to a higher care center. So that's all I have for this topic. I'm happy to take any questions for this discussion session later. Thank you.
Thank you, Dr. Evanshaw. Our next speaker is Dr. Brian McNally. He's from the Professor of Emergency Medicine, Emory University School of Medicine, Rollins School of Public Health in Atlanta, Georgia, but he spends most of his time in Ho Chi Minh City doing a lot of things. His topic presentation is a structured approach to trauma training to achieve high quality care. Over to you.
Xin chào. Tôi là bác sĩ Brian. That's it. So that is me, a little younger. But I'd like to talk to you today about trauma education and training. And this is the outline for the talk. I'm going to talk about, even though I'm going to talk about education, I'm going to talk about the system. You've heard this already today. You'll hear this more. But think of it as a learning trauma system that evolves over time. And think of each component. We talk about the chain, the links in each aspect of the bystander care, the pre-hospital care, hospital care, post-hospital care. there's obviously education that occurs with each of those groups. And the stronger those groups are linked together, the greater the success that the patient can benefit from. So we're going to talk about a framework for a learning trauma care system, and then talk about trauma simulation, and talk a little bit about CATSI, a course that colleagues of mine at Emory University developed that we've taught here a few times in Vietnam as well as in India, Pakistan, and Africa. So there's evidence. You've already seen some publications presented this morning to talk about the importance of having a system of care around trauma. You heard about the golden hour, and that term is been around for a long time. This idea that once somebody has a significant traumatic injury, the clock starts ticking, and the care that's offered is very important, but the logistics or the pre-planning, the integration of pre-hospital or ambulance care with hospital ER with operating room. If you train as a system and you work together, this patient is going to move through that system hopefully much quicker and get the care, the definitive care they need. My prior training before becoming a physician was working as a paramedic, EMT and paramedic in New York City. And the saying we learned when I was training was, this patient doesn't need more time on the scene. They need to be in the operating room. So avoiding delay, moving that patient towards care. Definitive care, we would say, would be cold steel and warm lights. I think you may have heard this term, operating room, right? You're in that environment. So getting the patient where they need to go, but the system has to train together and has to work together to be effective. But this article really suggests that where the development of a trauma system clearly has benefit, where that system in its stage of development from a primitive system to an advanced system will often, the patients will have greater benefit or decreased mortality as that system evolves and becomes more mature. So I think it's really important to understand that the beginnings, you don't have to have a helicopter service like you saw earlier to start out with. You need coordination, you need training, and you need basics. And we'll talk about this, that different, the resources that are available are what you're going to need to use. Chow Ray Hospital, as you heard this morning, very advanced care. That is not what you're going to find right in rural parts of Vietnam. So the idea of how can you train in those environments where you have less resources? And WHO has put out documents about this. But again, think of the system of care as these links. And it really is focusing on the bystander care, pre-hospital or ambulance, hospital, post-hospital. But it's also focusing on preventing that injury from occurring, right? Injury prevention, as well as data collection. Again, themes you've already heard about today. So you have to think of the whole system as a learning and evolving system over time. I'll just say this real quickly, the importance of injury prevention. I spent 1 year in Hanoi, and I've told some folks this story in the room that may know this already, but one night I came home from the airport late, and I was getting out of the Grab, and there was a crowd of people, and I knew something was wrong. And then I found out 2 young men had driven their motorbike into a tree at a very high speed, no helmet, at night, coming around Wang Kim Lake, and hit a tree head on. So I called my colleague who was in charge of the ambulance service and he said, "Are you okay?" Because it was 1:30 in the morning. And I said, "I'm fine, but can you send 2 ambulances here?" Both of them died, one at the scene, one later. Preventable. No helmets, high speed at night, and potentially with drugs on board. I know that things have changed here in a short amount of time in terms of the law has changed around alcohol use. That's a good example of effective policy to prevent injury. There was nothing you could do for these 2 young men. The event was over in a sense. You can't salvage somebody that has significant injury, but you can prevent future events. And again, the idea that you're focusing on injury prevention, a very important component. You heard earlier about Stop the Bleed, bystander education. Pakistan Lifesavers Program, another good example of teaching the public two things: compression-only CPR, person's in cardiac arrest, and hemorrhage control, direct pressure, elevation, tourniquet control. These are programs that develop differently, but the concept in Pakistan is trying to train 10 million people in 10 years. Very ambitious, but the idea of a low-resourced environment that's actually providing this level of care. The program in the US, believe it or not, is a national program. Unfortunately, it was originated because there was too many shootings in the US. People were dying from extremity wounds. So the idea of putting that together. When you look at pre-hospital care and focus on education, basic trauma life support course that's been around for a number of years is a great educational curriculum to use, but it's also understanding and practicing triage in the field as that patient comes in, minimizing time on the scene, getting that patient to the right hospital, and making sure you can advance notify the hospitals so they can prepare, ideally, a trauma team. Early notification, and then handing that patient off. This is a report that came out of the Institute of Medicine or National Academy of Science in the US, talking about trauma system development. I don't know if the video will play in just a bit to give you an example, but it really talks about the need or the importance of pre-hospital care being seamless, meaning the care in the field is integrated and coordinated with the hospital, that the hospital knows in advance so they can set up. I worked this past week in the US in a trauma center on Sunday, and we would get a notification. We have a level 1 trauma coming in 10 minutes. 22-year-old male, gunshot wound to the chest and extremity, has a tourniquet on, here's his blood pressure, here's his vital signs. Our estimated time arrival is 8 minutes. That tells us a lot of information. We already know which room he's going to go into. We're going to assemble the team. We're going to get airway. This only occurs with training and with practice. So the idea of having a coordinated, seamless handoff between pre-hospital and hospital, very important. This is the hospital I was actually working at on Sunday where this patient came in. Again, this is developed over many decades, the concept of a trauma system, a trauma team, trauma education, quality improvement around that process, and obviously having data to show that you're performing. Post-care is obviously important, rehab care, very important. You heard from Dr. Kim this morning, PATOS is a great example, a great tool. You guys are doing, collecting more data here than anywhere else in the country and in some major neighboring countries as well. I think the most important thing I'd like to emphasize, because you heard a lot about this morning, is you might not think of it, but registry and doing quality improvement probably will save more lives than in almost anything else we do. Stopping bleeding on the scene when a patient's got significant hemorrhage often is probably the greatest opportunity for saving a patient's life in this whole continuum of care. But data collection done in a way that you feed that information back to understand who are the patients you're caring for, what are the opportunities for preventing future patients, and how do we improve upon care? Are patients getting timely care? How long does it take to get a blood transfusion, as an example? So again, data is really important in terms of system and educating ourselves around that. So again, I'm not going to go into this because you heard this earlier. The example I'll give home, this is in Atlanta, Georgia. When these devices came out a few years ago, we saw a number of injuries. And the data we collected at our hospital told us a story. The first 3 deaths that occurred from people using scooters in our city that came to our hospital had the common theme. They all happened at night, and they all were patients or people riding these on a sidewalk to cross the street. So they're coming off the sidewalk, getting hit by a car. So what happened was the city changed the law and said you can't ride them at night and you can't ride them on the sidewalk. So again, as an example, using data to change, hopefully, policy and to prevent these injuries. I don't know if this video will play, but just see. Okay, you can take my word for it. This is just describing a trauma system, a development in the US. I think the most important point I'd like to make is the integration between the civilian sector, right, hospital-based care, and the military. There's a lot to learn from each other, a lot of exchange, a lot of, unfortunately, a lot of care that we learned about tourniquets, for example, have been because of the military saying, you know, putting on a tourniquet. When I started my training, we thought tourniquets were dangerous. Now we put them on very much more readily because of data from military members that have had extremity injury or extreme hemorrhage, and recognizing that applying that tourniquet really can save the patient's life. So evolving a learning education system, you change your protocol based upon you know, data. And this is part from that same report talking about putting a patient at the center of patient-centered trauma care. All the rings outside it are the things that we need to do that can enhance this framework for a learning trauma system of care. This WHO report, there was 2 reports that came out looking at both pre-hospital and hospital-based trauma care. One of my colleagues I work with helped put this report together many years ago. I think the important thing to realize is, you know, as you heard earlier, the burden of disease in Vietnam and in the region is very high. Locally, right, we learned that, you know, vast majority of patients at Chao Ray are coming in are trauma, and a lot of it is blunt, right? A lot of it from motor vehicle, motorbike. So if you understand who you're taking care of, you have a better chance of, you know, preparing and training to manage those injuries. This report really focuses on different levels of resources, and I think recognizing there's a hierarchy to trauma program development. Each hospital, a rural hospital, is very different than an urban hospital, but you need to understand what your resources are, educate around what those resources are, and do quality improvement. From a most basic hospital to a tertiary care Chao Ray type facility, you're going to have different resources. You should train based upon those resources. And examples here would be a basic hospital in this report suggests that, you know, basic training, they have a course called WHO's Basic Emergency Care course could be provided, collecting basic data. A more advanced or specialty hospital, you may do like an ATLS-like course or have other advanced courses and collect more robust data and have more education focused on subspecialty care. Again, as you have more resources, you have to adjust your educational programs. And I think that's an important thing. The concept of trauma education is not just the individual nurse or the individual emergency physician or individual surgeon learning their role. It's working together as a team. And I think there's data here that suggests that teamwork, trauma team training, not just trauma education, really can help move that patient through the system better. And the examples here are when that patient comes in, how quickly do they get a CAT scan? How quickly do they get a blood transfusion? These are process measures, harder to show clinical benefit, but the concept is if we know these things matter and time is sensitive, you can implement this at your institution and you can track these process measures to show that you're likely providing better care, but it has to be a team approach. And the idea of using high fidelity simulation, this has been studied as well. In the systematic review suggesting that there's benefit to not just training as a team, but also using simulation as part of your education, using mannequin and scenarios as an example, or even getting into the emergency department and simulating a patient going through, doing a mass casualty drill, of course. Those are the things that we know can make a difference. So again, a lot more data here to suggest that simulation should be part of the trauma education or trauma team process. So I'm going to end with, this is the course that I mentioned earlier, or the CATSI, Collaborative Advanced Trauma Care course. Emory University, where I come from, my colleague Anna Yafi helped develop this with colleagues in Indus Health in Pakistan. So we've had this course a few times we've done here, a train the trainer course, but this has been actually implemented multiple times throughout India and used more recently in Africa. ATLS is the standard course that we use in the US. ATLS doesn't exist in a sustainable form in Vietnam. It's too expensive. There's a lot of things that need to be in place. Our colleagues in Thailand know this, and I've learned from them about how did they implement ATLS at a country level. I'll just say this, it requires a lot of time, effort, and typically Ministry of Health involvement. This is a course that is really focused on basic education and trauma team. Nurses and physicians training together and simulating and doing drills in the emergency department. This is pictures from two of the original courses, one at Bach Mai colleagues there, and then one of the original courses in Indus in Karachi, Pakistan. It really focuses on, again, collaboration, a multidisciplinary approach, right? Emergency physicians, emergency nurses, surgery, as well as anesthesia. This is trying to recognize if you train together, when that patient comes in, that patient's likely going to be in a better position, but you have to actually go back and see that you're coordinating care. You can't just take a course and leave it at that. You need to go back and bring this to your hospital to say, how do we coordinate this patient getting the definitive care? As you heard this morning, massive transfusion protocol implemented, in Chowray. That's probably not available in other hospitals. Does your EMS system know, for example, 115 here, when a patient meets certain criteria, could you notify the hospital? Are they ready for the patient? All that requires education, but it also requires practice. And I think that's the piece. There's the clinical care, and then there's we'd say logistics of moving that patient through the system. So a lot of this is taught in the course. It's hands-on. We took the lectures after COVID and allowed them to be a pre-course so people can review the lectures in Vietnamese in advance. And then the actual course, the hands-on, is more surgical skills simulation. And I'll show you pictures here. You saw this slide before. This is why this is important. We know a lot of patients will die in the scene. There's not much to do for them. But that golden hour, that middle group, really there's an opportunity for intervention. So again, the goals of the course are working in a collaborative sense, multidisciplinary, nurse physician together. Primary and secondary surveys, super important, and that really can be taught in advance of the course through video, people understanding how to do initial head-to-toe survey, stabilize conditions that need to be addressed immediately in a hierarchical fashion, and then the trauma skills themselves, and then really putting it all together. So again, lecture, this was the course we did in 2019. We've done this now since. We've taken these courses, the lecture part, and provided that online in advance. You could thank COVID for that, so we don't use as much energy up front. Team building, practicing together, and the idea of working as a group. That's not a very great picture of me, but I'll say the idea of primary and secondary survey, and this concept of each person having a role. This may be very practical in a large hospital. In a small hospital, you may only have two people. It may be a nurse and a physician. You need to take this back to the facility to adapt it to the needs and to the resources that you have. I'm going to skip this video, but the idea using pig necks to do practice surgical crike, surgical airway, doing simulation. This is actually a Bach Mai, and really making sure that you've got the team. It's not physicians learning over here and nurses learning over here. It's working together and understanding that you need to practice as a team if you want to perform. We did before-after analysis. We showed physician knowledge went up a little bit. Nurse knowledge went up a lot, which is great. We've seen this in several courses. So there's the opportunity of increasing your knowledge, but also showing that there's greater effort from a team approach and efficiency, minimizing delays. So really, I think I'm going to just end here. That the important thing is each system has a different set of resources, focusing on the basics and focusing on the things you've heard about this morning already. We have to do a better job with pre-hospital care and bystander care. Pakistan is doing this, at a country level to try to train folks on stopping hemorrhage, right? That's certainly something that can be, I know is being done here, but has to be done more bystander training. Pre-hospital care is evolving, right? EMT and paramedic, I know this, right? Now exists at a government level. I know courses are beginning here as well as in Hanoi. That's exciting, particularly, like I said earlier, I previously have a paramedic background, so it's exciting to see that. This will take time, but each of these components, when they're put together, will improve care. And if you don't believe this, just look at your neighbors that have done this. Again, I think Thailand is a good example. Very similar type of trauma, a lot of blunt trauma, and it took decades for the system to really evolve. You're not that far behind in a sense, but it's putting these pieces together. So it's an exciting time to see trauma care development evolving here. Thank you for your time.
Thank you, Professor McNally. Our next speaker is Dr. Sata Riapan from Thailand. He's the Assistant Professor at the Emergency Department, Siraj Hospital, Mahidol University of Thailand, and also the Secretary of the Thai Board of Hospital Emergency Fellowship. His topic will be on trauma care system and quality assurance.
Hello, good morning, everyone. So thank you for the good introduction. So I'm Dr. Sattha Riyapan from Thailand. So okay. So today I would like to talk about the trauma care system. I would like to emphasize quality assurance in trauma care system, talking about the current evidence of the performance indicator in trauma system and challenge, and next, what is the next opportunity for the performance indicator for trauma care. And I would like to introduce our new tool from the Asia EMS, our pre-hospital emergency care system evaluation tools or PATOS. And some examples from Thailand about the trauma measurement in our country. So I'm glad I'm using the same picture with the Dr. Sabaria in the morning. So I know that Prof. Brian gonna go through about the prevention, pre-hospital, and post-hospital. So that's why I just use as one slide talking about the trauma care system and don't want to go to in any detail. However, the trauma care system is not just start from injury. Actually, it's before that as Dr. Prof. Brian just says earlier, it starts from prevention. And after injury, we need to the pre-hospital care system. We need to have a hospital system. After they discharge from the hospital, right now we need the good intermediate care, post hospital team rehabilitation to make them come back to have a quality of life again. So, and how we measure it, we're going to go to in this lecture. And the reason I got the sorry about the slide, and the reason I got this session, we have the protocol, education, and quality measurement, because this is how we develop the system, how this is the concept of the medical direction. How you lead the quality, you need to have protocol. How you implement the protocol, you need to have education that Prof. Brian just said earlier. And after that, how you know that protocol is work or not, you need to measure. So that's why this is come to my lecture about the measure the quality. Actually, talking about the quality management, they have the two words, the quality assurance and quality improvement. So my lecture, I'm gonna emphasize the quality assurance. The quality assurance mean you see the picture. We try to detect the below standard quality and move it to the current standard that we have right now. So to prevent it not have the below standard again. But the quality improvements, we try to move everything to the new standard, the better standard. So this is how we try to differentiate the two words, quality assurance and quality improvement. But this lecture, I'm gonna emphasize that's only the quality assurance first. And of course, the both of the quality assurance and quality improvement, you need to have the same concept about the measurement. You need to have the indicator measurement and have the next plan and improve it, or the prevent it to go to the below standard. And so that's why, and what is you're gonna measure? A lot of things that you need to know. Sometimes you can measure the quality, sometimes it's just efficacy, maybe just a time process to make it quicker, the speed that the Dr. Brian just said, you have the coordination, you make something more faster, And this is all of this is called the value of care, the better quality, or maybe you just read the same quality, but you can reduce the cost. That is something that make the value is much more better as well. So talking about the quality indicator in trauma, actually, as I reviewed this review, they have they found that more than 1,000 indicator used currently used right now in around the world, and not surprisingly, most of them in hospital indicator. And for the in-hospital indicator, so for talking about the performance indicator, I'm just gonna go a little bit basics. We we gonna divide to structure indicator, which means you have the protocol, you have the enough human resource, you have enough equipment, or the process. How process indicator that like a response time, the time to CT, and how you perform with the patients. And outcome is an outcome indicator is the result of the treatment, the death, or quality of life. If we're gonna go to a little bit, and you see, most of the indicator is just a process because it's easy to measure, and that's why we have to measure a lot about the process outcome, even pre-hospital, in hospital. However, we in the slide we see that we lacking of the gap about the post-hospital indicator, and even worse about the prevention indicator. So that's why we need to have at the system, we need to have that's all too. And this is the I gotta show you that it's a top 10 for that paper. The top 10 indicator, the most common indicator they use a mortality. The first one is a preventable mortality. We're gonna go to a little bit later. They have the review, the peer review. When you have the trauma death in your hospital, you have the committee to review is it preventable or not, and you collect as a rate of the preventable death. And next one is hospital mortality. Is it good or not? And this is they try to suggest as a system when you try to create indicator, you need to not just only in a hospital, you need to have the pre-hospital, hospital, post-hospital, and prevention indicator. And DY is in like a structure, process, and outcome as shown in slide. However, the challenges in the performance measure in trauma care right now, I show you we have like 1,000 indicator in around the world, but we don't have no international consensus that which one is the best. But the reason I think I agree with Dr. Brian is depend on your system. So if you have your system, which one you have to think which indicator is match with your system. So that's why it's quite difficult to create the international consensus for these topics. And as you see in my previous slides, the focusing mostly is in hospital, not in the system. So that's why we need to expand the indicator to measure from the prevention to post-hospital care. And they focus on the provider point of view. That's why they measure the process that much more than the outcomes. The ideal performance indicator, we need to the indicator that important, usable, and feasible, and have the evidence based on that too. So that's why we still lacking of the good indicator for the trauma care right now. For one example that we use a lot that I showed you in the previous slides, in-hospital mortality. When you have the two hospitals have the same number, same ratio of in-hospital mortality, I show you is in the slide, the 5% is the same. However, is it exactly the same? Can you say that the hospital have the same performance? The answer is no, because the patient in one hospital maybe more severe than another hospital. So that's why when you measure about outcome, a lot of the trauma system right now, we use a trauma score to adjust the trauma outcome to try to adjust to about the severity, and so that's why you can compare. Even you can compare with the last year. You need to adjust about your trauma outcome as well, and a lot of the trauma score. That's why currently we have a lot of the trauma score published, and you can use the one that you have feasible for you. In Thailand, I'm gonna show you. We still use the most common one is the TRIS score, and you don't worry about the math. But however, the TRIS score you can have this data if you have the trauma registry. That they have the score, severity score from your diagnosis. If you do trauma disease, you have the diagnosis. You can create like a injury severity score, revised trauma score. If you have the hemodynamic parameter like a blood pressure, respiratory rate, gas-hemoglobin score, and you can create the TRIS score. I gonna call this one is PS, and when you have the PS, this is like a expect outcome, like in this like when you have one patient, this patient have the what is probably to survive for this patient. They're gonna show you as a percentage, like if so when I got shot and go to hospital, and how what is probability of survival of me when I go to your hospital. The PS gonna show you about something like that, and you can compare. I'm gonna show you later how we use in Thailand as a performance indicator as a for trauma system later. And however, the PS score it is just for it's just an individual score, individual patient, but you can calculate. We call another one we call W score or W score, and W score that they're gonna this score they're gonna try that like a they're going to calculate the number of unexpected outcome per 100 patients, like a make you more expect as a system. But they still did focus on the outcome in hospital. For the trend of the trauma performance measurement right now, it's not just a mortality, because the same mortality is not the same performance. And even you adjust the score, it's not the same as well, because right now we move a lot of trauma system move from the just looking at the just mortality to looking more the functional outcome, more the quality of life. That's Dr. Prof. Sabarius show us about the daily and a lot of quality of life measurement right now about they measure the trauma outcome as well, and move from the short-term outcome to the long-term outcome. They just not just measure the just in hospital mortality. They follow them like a 1 year mortality to see the long-term outcome as well. And this is another example. So however, the published paper right now, the most of the indicator is in the developed country, most of them in the US. And for the developing countries, they publish about the indicator, just a small number right now. That's why it actually is a gap a lot in the developing countries, that they need the measure, the indicator to measure how they perform, and they're going to improve it. So that's why Prof. Marcus and his colleagues he has a group to create the tool called the PATOS, Pre-Hospital Emergency Care System Evaluation Toolkit. And actually they have the workshop. They use the Delphi method. They gather the expert from the Southeast Asia, actually include your colleagues from Vietnam as well, to go to the Singapore, have the vote about which one is important for the developing country to measure. Most of them is a structure measurement. I'm going to show you a little bit. This is they start with the online voting first, and come to Singapore to discuss which one is important for each system. So for summarize, right now we have the the core element, 12 element that show you you need. If you start with the basic system, this one you should have first before you go to before you're gonna go further. You don't have to talk about the helicopter if you don't have something like this in 12 elements. So this is like a basic system that we vote that is very core element for the developing system. For some example from my country in Thailand. In Thailand, we still try to develop the performance trauma system. Trauma system is one thing of the emergency care system. So Ministry of Public Health involved on this to create the performance indicator for the emergency care system. They start most of them is structure indicator, and they go around the country from the user concept of household accredited HA, the household accredit, to identify the gap from each system, and they summarize. And so right now we can know which region lacking of the emergency care system, and we can promote it more, something like that. And this is the previous one is from Ministry of Public Health. We also have the National Institute of Emergency Medicine called or NIEM to work mostly on the pre-hospital care. This organization created the performance indicator just last year called the Provincial Emergency Medical Service Performance Scoring Index, or abbreviation is PEPSIS. They try to develop from the concept of the EC from the visual. They use the structure, process, outcome as well. But they just start measurement just last year as the first year that we use, and they try to follow it as a trend later, and then you can compare province by province. That this province had a better performance for another province for benchmarking, and see how we improve it later as well. And another example for specifically for the trauma system, we have the good model for the trauma system in Thailand. If you're going to go to Thailand talking about trauma system, don't go Bangkok, my city, Bangkok. So go to Khon Kaen. Khon Kaen have a good system. So they create the performance indicator. They set up the team for the data collection. They have the regular meeting for all the stakeholders from the pre-hospital, in hospital, everyone that involved the system. They have the meeting together. They have the regular training, and they have the regular outcome measurement, like a trauma audit for when you have a death mortality case. And after they implement the concept, look like this, so that they can show that the mortality rate of them decreased year by year. So right now, as a Khon Kaen as a model from our country, so all around the country in Thailand right now for the trauma, we use again come back to the TRIS score, the PS. If the PS show you like this patient have probability to survive more than 75%, they should alive. If they die, there's something wrong in your system. So we count. So for 100 patients, if we have more than 1% that the patient should survive, but they die, is there going to be a problem for us right now? So that we keep using KPI, I think more than 10 years for monitor our system as an outcome measurement in our countries. And how we get this data for the TRIS score, we implement the data measurements with the injury surveillance system that this measurement, this registry, our injury surveillance is focused on epidemiology data. I think that we have a similar problem about road traffic injuries. So the main focus of the injury surveillance is the road traffic injury. They even have the checkbox about the helmet passenger. something like that. So and then this data can come back to TRIS score, and we can use this data to monitor about the trauma KPI in our country. However, we still, as I show you about the trend, we don't have the functional outcome in this surveillance yet. It's something that we need to improve later. However, if you can measure functional outcome, you need to have the human resource because you have to ask the patient survey to about it's not just a yes or no. So you have to have the team or some funding as well. So that's why we don't have that yet right now. From our take-home message, so quality assurance is a systematic approach. From performance indicator, we divide to structure, process, and outcome. And ideal performance, we need to have the important, feasible, and have more evidence based on that too. The trend from trauma outcome is moved from just collect only from mortality to functional outcome, from short-term to long-term outcome, and from hospital performance to measure the system performance. And Thailand, we see working on that. Last slide, one of my take-home messages. This is my first and now because I just finished my meeting in 11 a.m. we changed actually we changed the date of the next EMS Asia and changed the place to the Sheraton Hua Hin Resort. And this resort we gonna close. we're gonna close the resort, and we're gonna have the EMS championship at the pool and on the beach. Quite Hua Hin, yeah, Hua Hin, not Pattaya, Hua Hin. But we're gonna have the transportation from you from the airport to the Hua Hin safely. Please come, save the date, and please come in February and 18 and 20. Oh, sorry, 2025. Sorry. Oh, next year, February next year. See you later. Thank you very much.
Yeah, thank you very much for your presentation. Bây giờ thì chắc là mình sẽ chuyển qua cái phần discuss nha. Thì ở đây thì mình là chủ yếu là của Việt Nam mình rất nhiều, cho nên là Thảo chỉ nói như vậy để cho các bạn của các nước người ta cùng biết. Thứ nhất là hiện nay thì Việt Nam nằm ở trong cái nhóm mà trung bình, gọi là trung bình thấp. Thứ hai nữa là cái hệ thống cấp cứu của mình thì bây giờ là nhân lực rất là yếu. Mình phải nhóm lại 3 cái. Thứ nhất là cấp cứu, hồi sức và chống độc cùng triển khai, và cũng không có đủ nhân lực. Thì hiện nay thì rất là cảm ơn tất cả các cái bạn ở trong cái nhóm chuyên gia của PATOS hiện nay đang qua Việt Nam để mà triển khai một số cái giúp cho Việt Nam. Thì cái hệ thống cấp cứu hiện nay đối với lại hội hồi sức hội hồi sức Việt Nam thì là gần như là phân hội cấp cứu của Việt Nam sẽ làm cái nhiệm vụ này. Và đối với lại các vùng miền thì là gần như chúng ta kết hợp lại để mà cùng nhau để triển khai cái cấp cứu. Cho nên là có rất nhiều tất cả các cái thành viên mà hoạt động trong cái hệ thống cấp cứu đó, thì Thảo cũng rất là muốn các bạn cũng có những cái ý kiến trong cái vấn đề là mình triển khai cái hệ thống cấp cứu ở Việt Nam thì nó có thuận lợi như thế nào và chúng ta phải làm như thế nào. Chứ hiện tại thì những cái lớp để mà triển khai cái EMS của Việt Nam thì chúng ta đã làm rất nhiều. Nhưng mà để mà triển khai cả một cái hệ thống với các cái phần như là về nâng cao chất lượng, đánh giá hiệu suất, rồi tất cả những cái khác như là cái bạn ở bên Thái Lan, cũng như là một số các cái bạn ở Manila, rồi ngay cả như là giáo sư mà Brian McNally là đến Việt Nam là để triển khai cái này 10 mấy năm rồi. Nhưng mà chúng ta thấy rằng cái nhân lực của mình nó vẫn cứ thiếu. Và rất là may là trong cái đợt 2023 này là gần như là chúng ta triển khai cái luật khám bệnh chữa bệnh mới. Thì trong đó cái cấp cứu ngoại viện của mình đã đưa ra được một cái mã gọi là cái mã ngành để cho chúng ta có thể thực hiện những cái phần mà chúng ta sẽ triển khai như thế này. Thì cái đó là những cái phần mà Thảo muốn nói để cho các bạn ở các nước á, người ta hiểu được cái vấn đề ở Việt Nam mình nó không phải như ở Thái Lan là triển khai cái hệ thống cấp cứu nó riêng một mình được, mà hiện nay là mình cấp cứu nè, hồi sức nè, chống độc nè là nó chung với nhau hết đó. Và khi triển khai cấp cứu cũng rất là khó khăn, nhân lực chúng ta cũng rất là khó, và hiện nay để giữ người ở hệ thống cấp cứu, đặc biệt là cấp cứu 115 đó, thì mấy bạn thấy rằng cái giờ giấy phép hành nghề còn chưa có nữa cho nên rất khó khăn. Thì không biết các bạn có cái ý kiến gì không? Mời các thành viên mà trong cái lớp học á, chúng ta cũng phát biểu để cho các bạn hiểu, chứ còn các vấn đề này mình học mình biết hết, nhưng mà khi mà triển khai rất là khó khăn nha. Yeah.
Thank you, Dr. Tu. Is there any questions you want to ask any of the speakers? I just would like to make a comment. I agree with you that the ATLS is not very sustainable in poor resource countries. We have an ATLS, but we can only train very few people. So like you did the CATS, we have come out with our own, what we call a Malaysian Trauma Life Support Program. So probably some of these areas will move away from the ATLS system of training and education. Okay. So if we do not have any more questions, I'd like to thank all the three speakers, Dr. Ivan Chua, Dr. Brian McNally, and Dr. Satari for an excellent presentation this morning. Thank you very much.
Thank you. Now please we invite Dr. Ivan Chua, Dr. Brian McNally, and Dr. Satari Yaban go to the stage to receive the certificate from host. We have a lunch. Sau cái phiên này thì
anh chị đại biểu từ các nơi đó ở Việt Nam đó thì xin vui lòng nán lại hội trường trước khi mình ra mình nhận cái suất ăn trưa. Có một số vấn đề xin ý kiến của các anh chị chút.
the introduction of the core standards for acute trauma care in 2013. With more hospitals coming up in Singapore, not all the hospitals had equal capabilities, and we decided to do pre-hospital major trauma diversion in 2014. That means if you are in a region where you are not near a major trauma center, then you'll be sent to a major trauma center if your injuries are quite severe. We'll take a look at the map later and I can explain. And we had a national trauma unit that was established in 2017. The hospitals all got accredited to deliver trauma care based on the core standards. And we had 3 NTC subcommittees to focus on the key areas of our trauma system in the early 2020s. Okay, so this is a map of Singapore. As you can see, the trauma group is actually divided into 3 major groups. So we have the Western Regional Group, the Central Group, as well as the Southeastern Regional Group. But of course, this is actually just based on geographical location, and the population they serve is actually quite different. The central part is not that big, but it actually serves the bulk, at least about half of Singapore's population of 2.8 million. And the southeastern side is where I work in. We serve about 1.3 million population. And the west side is actually the largest cluster, but it serves only 1.5 million. So for instance, if you are in Ng Teng Fong General Hospital, which is one of the more peripheral hospitals, and you have a major accident, you actually may get sent to the bigger hospital in that cluster, which is the National University Hospital. So over there, they'll have services like cardiothoracic and neurosurgery, which are missing in Ng Teng Fong General Hospital. And KK Women's and Children's Hospital is right smack in the center of Singapore, and they serve all the children who require pediatric trauma support. So the national level Ministry of Health actually looks at the national trauma policies, and they actually own our trauma data. These 2 smaller committees, which is the National Trauma Committee and the National Trauma Unit, come under the Ministry of Health. And under the National Trauma Committee, there are 3 different subcommittees which look at different things like the outcomes and quality assurance, training and education, as well as emergent issues. So next, we'll have a look at the Omni system. We'll help you to appreciate the patient's journey from the time that they pick up onto the arrival in the hospital. So Omni is our new electronic system that has been used since 2-3 years ago. Before that, everyone was using pen and paper, but with this new system, it's all electronic. So can we have the video?
Hello, 995, what's the emergency? Yes, ma'am.
The person number is 995. Actually, assess the patient's record. You have learned before arriving. Ambulance crew is 3 people. You have the driver, the paramedic, and then EMT.
The chance that traumatic feature and need to call the active traumatic assemble all the team members, then let's prepare the result. The job will be in charge of airway, so let's prepare the airway set for the acute. Simply reduce circulation.
Okay. So this is his existing injuries. It has abdominal contusion and also active bleeding over the right lower limb. May you proceed with tranexamic acid infusion for this patient?
Okay, proceed.
Okay, so we will administer 1 gram of PAK, doctor.
Yes, proceed on. Thank you.
Hello, 995 was emergency.
This is the first version of the operating system. We are coming out with version 2, so hopefully there'll be some improvement. All right. So I showed this earlier regarding the protocol for the major trauma. So I'll just move on. So there are special diversion criteria as well. Like for burns, more than 15% second degree, we'll send it to a specialized burn center. So that's the other one. And of course, if it's a pediatric, then they go to the pediatric center. So in terms of a trauma kit, this is some of the equipment that we have in our ambulances. So for instance, if there's a patient who needs to be extricated from a car or a vehicle, then they can make use of this green thing on the top right-hand corner, which is called the Kendrick's extrication device. So the paramedics will safely extricate the patient and from the vehicle and put into the ambulance. We also have things like box splints on the bottom left-hand corner to immobilize any fractures. And there is a teapot of pelvic splint, as you can see in the middle. And the bottom right-hand corner is a tourniquet that we've mentioned earlier. So this is a snapshot of what we actually see from the Omni system. So this is actually the paramedics' view, what they require to key in. So there's actually a diagram of a man, and they can actually indicate the injuries, they can draw on it. Then of course we also ask certain things like whether the patient has required extrication, whether there was any immobilization done, like head mobilization, cervical collar, backboard, pelvic binder, so on and so forth. And we also ask for some details of the road traffic accident, because all this information actually goes into our national trauma registry. So we need to know things like whether the patient was a driver or was he a passenger, and whether he was wearing a seatbelt, whether the airbag was deployed. So in Singapore, all these centers have a trauma team, and the trauma team composition is more or less the same. So far as I know, it's just a single tier system in Singapore, and we have a trauma team leader, which is either an ED physician or a trauma surgeon, and we have an ED doctor, ED nurse, general surgery resident, or orthopedics resident. So the role of a multidisciplinary team is really to assess the patient together and make sure that the decisions are done quickly so that the patient can receive the best care. So in a way, the way the things are run, it should be quite similar in the sense that the person who is taking care of the airway should stand at the head of the bed. And then to his left, maybe someone who is looking at the vital signs or setting an IV. And on the patient's right, it will usually be the trauma leader or a resident who will be doing assessment like a primary survey, doing ultrasound, like a fast scan to see whether there's any free fluid in the abdomen. And the nurse usually will be recording some parameters and checking out the timings of interventions done. And of course, we have the radiographer who will come in and do the x-rays as necessary. And of course, we'll send the patient to the scan room to do a CT scan as soon as possible. So for trauma team activation, this is just a snapshot of our criteria in my hospital. So similarly, we divide into physiological, anatomical, and mechanism of injury. And like I mentioned, the purpose of a trauma team is actually for a multidisciplinary team approach so that things can be done quickly and everyone has a specific duty. Everyone needs to know what they have to do when they're there. And of course, sometimes there can be additional disciplines that we require. For instance, a patient who has a low GCS and maybe a blown pupil, we will probably have to call a neurosurgical team to come down. Patient with severe burns, we'll need to call in the plastics or the burns team. And patients who have maybe a traumatic aortic disruption, we will need to call in a cardiothoracic surgeon. So all these are additional ones that we will call in after the initial assessment and maybe the imaging has been done. And of course, with a team, we actually have more people on board that can help to resuscitate the patient. So we have more people who can help with setting of lines like trauma lines to give things like blood products, IV TXA. We also have more people who can help to do life-saving procedures like resuscitative thoracotomy, which is usually done by the ED consultant or with the general surgery registrar. Chest tubes insertions can be done by any residents. And also have to prioritize the imaging required, especially when we have 2 or more patients who come in and we only have 1 scan room. So we need to decide, whether which patient should go to the scan room first. And of course, we also need to come up with a management plan to see whether the patient needs to go to the OT or to the angio suite for angio embolization, to the ICU, or can the patient just go to a general ward and wait for further treatment subsequently. So investigations will always be done in the ED. This will be things like bedside ultrasound, which we usually do E-fast, and we also send out some laboratory to make sure the patient is not anemic, make sure the renal panel is fine. We also try the coagulation profile, Grove and cross match, liver function test, amylase, lactate, as well as cardiac enzymes. For radiology, we'll start with basic ones in the emergency department. So for X-rays, we usually do a chest and pelvic X-ray. And CT, we can do a PAN scan, which is a brain, spinal spine, thorax, abdomen, pelvis. If need be, we can do angiography if, let's say, they have a pulseless limb. And if they have some kind of cervical spine issue or some kind of a spinal cord syndrome, then we can always ask for MRI subsequently. So we'll try to do our best in the emergency department through the principles I've mentioned previously of permissive hypotension as well as hemostatic resuscitation. And then subsequently, we'll hand off to the surgeons to do damage control surgery. So as with everything, there's a need to actually have a continuous learning. So amongst the different centers, we all have learning opportunities with all these online training sessions. So the central region they actually have online courses that they do every month. So this is an example. If you're interested, you can scan the QR code and then attend as well, because it's over Zoom. And they'll be talking about 3 memorable cases for open abdomen. That's all I have for this presentation. Just a heads up, Singapore will have an annual scientific meeting, which is the SAMS ASM in February 2025. This will be on the 27th and 28th of April of February. So if you're interested, more information will be provided in time to come. So just take note of the dates. Thank you.
Thank you very much, Dr. Iwan. So I would like to introduce next speaker, my colleagues from Thailand, Dr. Prinya Thiemviboon. He is an assistant professor from the Department of Emergency Medicine, Faculty of Medicine, Chiang Mai University, in northern part of Thailand. So he's gonna share us about the trauma care system of Thailand. Please welcome Dr. Prinya Thiemviboon.
Okay, hello everyone. I'm Dr. Prinya from Chiang Mai University. Today I have the topic that will share you about the trauma care system of Thailand. Maybe it has something that you can adjust to your system. Okay. First, I will start with the system of the Thailand. The trauma care system of Thailand comprised of the 2 main components. First is the pre-hospital trauma care, and second is the in-hospital trauma care. I will start with the pre-hospital trauma care system. In Thailand, we have the National Institute for Emergency Medicine that creates and sets the law and regulation for the control the pre-hospital trauma care. If we have the accident that's like this, and the people saw the accident, the victim, so the people will call the emergency medical number 1669. Because of in Thailand, we don't have the universal number for all emergency condition. If they want to contact with the police, call 191. If they want to call to the firefighter, they call 199. But if they want to contact the medical ambulance, 1669. Almost the patients can remember 1669. So it's very popular for anyone. Snake attack their home, call 1669. Or thief go inside the house, call 1669. If they call the 1669, the call will direct to the emergency dispatch center. Emergency dispatch center have the call taker. Call taker will collect the details of the injury or the event and send the detail to the emergency medical dispatcher. Emergency medical dispatcher will categorize the emergency and the severity and give the response code red, yellow, and green. After that, the assistant of emergency medical dispatcher that we call the coordinator will contact to the ambulance, the nearest ambulance, and send the ambulance to pick up the patient. And when the ambulance go to the scene, after the treatment, ambulance will bring the patient to the nearest hospital. If they have any problem, they can call to the emergency dispatch center. The medical director, who is the chief of the dispatch center, will give the medical direction, online medical direction. National Institute of Emergency Medicine, they set the levels of the EMS unit. At the present, we have the 3 levels. First is the first responder. The second is the basic life support unit, and the last is advanced life support unit. Almost the ambulance in the hospital, from the hospital, is advanced life support unit. And the first responder is a volunteer in any area. In Thailand, we have the first responder more than 5,000 units and advanced life support more than 1,000 units. And National Institute of Emergency Medicine, in the future, they try to change it to basic, advanced, and specialist units. The specialist is just like the example of specialist units in my hospital is the Sky Doctor, the team that go with the helicopter to pick up the patient. And in Bangkok, we have the specialist units, just like the stroke team or the toxicologist. And about the levels of EMS personnel, we have the EMR is the lowest competencies, and the EMTB, emergency medical team, emergency medical technician basic, and emergency medical technician, emergency technical intermediate, and advanced emergency medical technician and emergency medical technician paramedic. So we have the 6 level. Any level have the different competencies. To scope and responsibility and limitation of practical medical personnel, National Institute of Emergency Medicine sets the law and regulation and scope the level into 5 levels for the medical personnel. Level A means the procedure permits to be performed. And level B permits based on protocol. The medical personnel can perform this procedure if we have the offline protocol. And level C is permit based on the direct medical direction only. Maybe the team call to the emergency medical dispatcher and medical director give them the online protocol. They can perform this procedure. And level D permit only if the doctor stay or perform at the scene. Supervision of this procedure at the scene. And level E not permit for this procedure. The example of this procedure just like the adult orotracheal intubation. EMTP paramedic can perform if we write the offline protocol. Advanced EMT, EMTI can perform if the doctor stay at the scenes and supervision them to do. And EMT, EMTB, or EMR not permit to do that procedure. And we set the response time to treat the patient outside the hospital. Response time means the duration time from receive the call from caller to the ambulance team arrive at the scene. Depends on the code from the emergency medical dispatcher. If that patient was received the red code, the FR team, first responder, have a limit time to go to the scene within 4 minutes, and advanced life support team within 8 minutes. If the yellow code, first responder go to the scene within 8 minutes, and basic life support team go to the scene within 15 minutes. If the code green code, only first responder go to the scene, no time limit. But if the dispatcher give them the white code, not send any team, they have to go to hospital by themselves. Okay. The standard of care in the pre-hospital care, we use the pre-hospital trauma life support. The step is the X, A, B, C, D, E, as the slide, and limit the scene time within 10 minutes in the severe case. Because of some area in Thailand is the remote area, and some areas are wilderness. Just like in my region, I work in the region 1 in the north part of Thailand is mountain, so very far from the hospital. The patient have to bring the injury patient walk top of the mountain to the area to the hospital. So it's very hard to do that, and the outcome is worse. So we need the helicopter, we need the sky doctor, but the main problem is we don't have any money to buy the helicopter. So we contact to the military and the police and collaborate with the military and the police, set the MOU to use their helicopter and set the Northern Sky Doctor team. After that, National Institute of Emergency Medicine set the policy, one region, one Sky Doctor. So in Thailand, we have many teams of the Sky Doctor. The primary mission is bring the patient from the scene to the hospital. And the secondary mission is bring the patient from the primary hospital to the university hospital or tertiary hospital, because some primary hospital is very far from the university hospital. Just you see on the slide, some hospitals take time if they transport by ground ambulance, use more than 5 hours. So the outcome of the trauma patient is worse. So we use the Sky Doctor to inter-facility transport, hospital to hospital. We also have the medical boat ambulance in the southern part of Thailand by collaborate with the Navy and the private agency. The primary mission is bring the patient from the island or on the sea to the hospital. And security mission is inter-facility, the same as the Sky Doctor. And about the in-hospital trauma care system, the Royal College of Surgery of Thailand set the level of the trauma center into 4 levels. The level 1 is the comprehensive trauma care. This level has the training, is the training center for the general surgeon, trauma surgeon, and emergency physician, and have the research for improve the quality of the trauma care. This will have the 24-hour in-house covered by general surgeon, trauma surgeon, orthopedic, cardiovascular thoracic surgeons, or microsurgery. And this level receives the referral of injured patient from level 2, 3, and 4 trauma center. The next is the level 2 trauma center. This level is the tertiary care or secondary care. They can cover all of the 24 hours of all injury, but they don't have some specific disease, just like cardiac surgery. They have to transfer the patient to the level 1 trauma center. And the level 3 is the provincial hospital. This level has the emergency medicine, general surgery, or orthopedic surgery. If we have the complex case, transfer them to higher level of trauma care. The last one is the level 4. This level don't have the surgeon. They have only the general practice doctor that train the ATLS course. The ATLS course is the standard of care in the emergency department in Thailand. The approach, the step of approach is the ABCDE. And we try to contact with the general practice doctor and send the general practice doctor in any hospital to train and certify this course. In university hospital, in my hospital is the Maharaj Nakhon Chiang Mai Hospital, is the level 1 trauma center. We have the criteria to activate the trauma team, the same as the Singapore. But the trauma team in my hospital the member is only the trauma surgeon. The trauma surgeon staff, the trauma surgeon fellow, and the trauma surgeon, the general surgeon resident, they contain about 5 to 6 members in the team. If we have the meet the criteria of full team activation, just like on the slide, you can contact them. But if you want some of the member to give your opinion or join to exam or reevaluate the patient, only partial team activation. The trauma team will go to the emergency department within 15 minutes. And we have the massive transfusion protocol for trauma because in the severe case, that estimate blood loss more than 30% of the total blood volume needs more than packed red cell. They need the coagulation factor, the platelet, to improve the outcome. So we set the criteria to activate massive transfusion protocol. By the physiologic is we found the hemothorax or bleeding in abdomen. And we estimate that blood loss more than 30% and have the physiologic criteria that one of the following heart rate more than 120, low blood pressure, serum pH less than 7.2. So we activate this protocol and give them the whole blood. Why whole blood? Last year, we give them the packed cell, FFP, plasmocin plasma, and platelet. But from the research, whole blood has better outcome than 3 components. So this year, we use the whole blood. And we set the fast track severe traumatic brain injury in emergency department. The goal of the this fast track is the patient visit to our emergency department to the ED exit within 60 minutes and transfer them to the operation room to start the incision for cranial surgery within 120 minutes. By set the criteria as on the slide, after we implement this protocol, the mortality rate in operation room was decreased just like this. So if you want to improve the outcome in the trauma case or severe traumatic brain injury, you may set the system or some fast track that you can perform or collaborate with any agency. Then the next is the video that I will summarize the system. Okay. This is the review last year in the southern. Okay. So you will see to develop the system, we have to collaborate with many agencies. So the effective system born from the good collaboration, and the great system will lead to the greater outcome. Okay, that's all of my presentation. Thank you very much.
Yeah, thank you very much for your presentation. Next topic, I would like to invite Dr. Saparia Faza Zamaluddin, visiting consultant, emergency physician, hospital, and Sun Abdullah. And please.
Xin chào and a very good afternoon to everybody. I'll be talking about the trauma care systems in Malaysia, and if you can listen to my talk, it's quite similar to what's happening in, for example, in Thailand and Singapore, right? And I like to thank the organizing committee to allow me to share about the trauma care systems in Malaysia. Malaysia is a small country in that corner of the world, and we are quite close to each other, to Thailand, Vietnam, Laos, Indonesia. So the Southeast Asian country, we are pretty close together. Malaysia is divided into two parts. On the left of your screen, that's the Peninsular Malaysia, and on the right of your screen, that is the states of East Malaysia of Sabah and Sarawak, which is on the island of Borneo, and we share the island with in Indonesia. The Peninsular Malaysia is more of the part of Malaysia that's more developed compared to the eastern part of Malaysia. We have many things unique in our country. We have the most largest and the stinkiest flower. That's the Rafflesia, the big flower that you see there. We have the most delicious and stinkiest fruit, the durian. We have the national flower, hibiscus, and I think even Korea has hibiscus as the national flower. So we do shade the pink hibiscus for Korea, right? And we have the Malayan tiger, which is our national emblem, the orangutan. And we once had the tallest twin towers in the world. So, but we are still the tallest twin towers in the world, the Petronas twin towers. We have many ethnic people in our country. We have the Malays, like me, is the majority of the population, Chinese, Indians, and the Bumiputras, the origins of the country. Our total area is about 331,000 square kilometers. It's nearly as big as Vietnam. However, Vietnam's population is 3 times that of ours in Malaysia. 33 million in Malaysia compared to about 98 million, if not mistaken. 98 million population of Vietnam. Our capital city is Kuala Lumpur. That's our financial capital, and our administrative capital is at Putrajaya. We have 13 states and 1 federal territories. We have 160,000. We have 160 public hospitals, which caters for more than 47,000 beds. But there are more private hospitals, but less beds. So the public hospitals are free, a very, very minimal charge. It's about 20 US cents to a visit to emergency department, where you'll get all the investigations and drugs and treatment to be given, less than 20 cents. Our physician ratio in Malaysia is 1 to 2.2 per 1,000. If you compare with Vietnam of 0.2, Thailand of 0.9, and Singapore 2.4, and South Korea. So pretty low still in Malaysia, and of course in Vietnam. If you look at the cost of death in Malaysia, as any developing country, it's at the same thing as around this region. Ischemic heart disease is the primary cause of death. But the death through injury in Malaysia is our 5th most common cause of death. And if you look at the ages where they die, 19.2% of the patients who die from injuries are between the 15 to 40 years old. Again, as I said before in previous lecture, these are the time that they are in the reproductive age group. So unfortunately, these are the young people on the motorbikes or going on the roads, drive very fast, do not follow rules. And during this Eid festival time, a lot of people go back to their hometowns, and they do have a lot of accidents in Malaysia during this time. The same thing, I think, in the Lunar New Year, if you go back to your hometowns, a lot of accidents will occur. So injuries and from road traffic accidents are a major cause of trauma in our country. Again, it's talk about the cost of trauma. In the death per year, it's about more than 6,000. Now it comes about to 7,000, but I think it has stabilized about 7,000 plus since after the year 2020. But the cost of it has gone up, right? From 8.7 billion ringgit, that's about 2 billion US dollars, to about 20.6 billion the cost. And WHO estimates, right, that it's about 24 billion, right? And it's 23.6 fatalities per 100 population. That's still very, very high as compared to the developed country. So we talk about the trauma systems. What I will discuss about the trauma system in Malaysia is to cover 3 areas. It's not comprehensive in the time that I have. So what I will talk about in the little bit of the pre-hospital care, the hospital care, and of course the on the research and audit part. As for pre-hospital care, I think that's one of the things that our areas of interest here is to look into the pre-hospital system in Malaysia. And during the discussion that we had on our visit to the ER here, that is it's pretty similar to the one that we have in Ho Chi Minh City. We have a universal number that started in 2007. Before that, we have 6 or 7 individual numbers. You want to call the hospital, you call direct to the hospital. You want the fire, you call 994. You want the police, don't know what number. You want to call hospital, you call 999. So in 2007, the government integrated everything, and they have a one universal number, one Malaysia, one number. That is the 999, right? So the 999 calls, if you need for any of the emergency services, the ambulances, the police, the fire and rescue, the civil defense, you call 999. That 999 calls goes to a telecom communication center. If you want to have the police, the telecoms will pass it to the police. If you want it, an ambulance for any medical condition, the telecoms, the 999 telecom center will direct it you to the nearest Malaysian Emergency Coordination Center, or we called it the MACC. There are many MACCs over in Malaysia. It is distributed through all the states in the Peninsular Malaysia, and over on the East Malaysia, over in Sabah and Sarawak. There are about 22 MACCs in the country to cover to cover the whole country. So let me go through the system or through the flow of what happens in case of an accident or injury. Generally, what happens mainly across the states of Malaysia. If there is an accident, they will call 999. From the 999 telecom center, they will divert the call to the nearest MACC. Let's say the call goes, there is an accident around in Kuala Lumpur, our capital. We'll go to the nearest MCC in Kuala Lumpur that is at Hospital Kuala Lumpur. The MCC are hospital based, so they're based at hospital. For example, for this case, accident in Kuala Lumpur, if it's nearest to the Hospital Kuala Lumpur, the call will be directed to Hospital Kuala Lumpur. From Hospital Kuala Lumpur, either Hospital Kuala Lumpur will send their ambulance to the scene, or will direct the nearest fire rescue or the civil defense or the St. John to the scene. Mainly the hospital or the hospital care in Malaysia are usually hospital based. It's run by the government service and it's based in government hospitals. The fire rescue, the Red Crescent, the St. John Ambulance Brigade, and civil just help to cover some of the areas. So other than the hospitals, the government health clinics also helps to response to our emergency call. So being at hospital, the hospital might not be in a good hotspot area, so it do take some time, right? Once a hospital responds, or the health clinic responds, right? The usual thing it is sent to the nearest hospital. If it is at the district, they will send it to the nearest district hospital, right? If the district hospital do not have the trauma capability, they will then later on, after resuscitation, send this patient to the nearest appropriate hospital for the trauma care. Or the patient, if the patient is near to a trauma capable hospital, the patients will be sent to the trauma hospital. So it's and I heard about the 115, that if you call the 115, that caters about 25% to 30% of emergency call, the cases get sent to the nearest hospital. So the same thing occurring over in Malaysia. Once the ambulances brought the patient to the emergency department, they are all brought to the emergency department, whether they are specialist hospital or district hospitals, they are already sent to the ED to be resuscitation. In hospitals where the emergency physicians will be the main trauma team. There are not many hospitals that have trauma team activation system in their ED, even for big hospitals. So most of the EDs will practice a two-tier trauma team system, which means that the ED team will see the patient first. If they require, they will quickly call either the surgical, orthopedic, or neurosurgical team. There are a lot of hospitals in our country that is surgical capable, which means that they can do general surgery, they can do the trauma patients, but there are very few neurosurgical hospitals. So if this patient if they arrive at your ED and the patients need to have a craniectomy, they will later be sent to neurosurgical capable hospitals. Once they are resuscitated at the ED, in which I found out now, a lot of hospitals do have the massive transmission protocols, especially the big hospitals. And they do have giving transaminase acids, the same thing as what's happening in Singapore, what's happening in Thailand, the same process undergoes in the ED in Malaysia. From that, either the patient can go to ICU if they need ICU care, or go directly to the operating theater where the surgery is done, or they can be transferred off to another hospital or sent to the ward if the patient is stable. The patients need interventional radiology, or they need CT scans, they'll send to the radiology department. We don't have many interventional radiologists in our country. A lot of them has gone to the private hospitals, and as I said, the private hospitals are not part of our trauma system. So a lot of patients do end up, if they require, under the surgeon's knife. Once the patient recover, they are sent for rehabilitation. The rehabilitation team do see the patients a lot, quite early. We do have a national rehabilitation hospital in Kuala Lumpur, but our rehabilitation system or centers are far in between. I myself, I need a rehabilitation appointment. It takes me 1.5 months to get a rehabilitation appointment. So I think this is one area that we really need to look after. All right. So we have our pre-hospital care system, right, which are hospital-based. And then we send them to the nearest hospital. And that is really very an inefficient way to treat the trauma patients. So we are discussing about having a trauma bypass system, having an ambulance system that is put together rather than being hospital-based. So because we know this deficiency, around the Kuala Lumpur area, we have tried a pilot project called the Klang Valley Ambulance Service, or KVAS, that pulls all the ambulance in the Klang Valley, in the Kuala Lumpur area together. They run their own MCC, but the coordination is done by one center, right? So which means that now the ambulances are no longer hospital based. The ambulances can be put anywhere by the KVAS system. And then the paramedics, our paramedics that runs the ambulance system is different from the rest. Here you have the EMT-based system. For ours, we have like what we call the physician assistant. They are diploma, they're like nurses, right? But they can do things to assist the doctors and do other things by themselves. So before this, our paramedics divided between helping the pre-hospital care and helping in the emergency department. So today you can be working in the emergency department, tomorrow you can be working at the pre-hospital care. So it's not a very efficient way to share resources for pre-hospital care. So in the KVAS system, in the Klang Valley Ambulance Service pilot project, they have given X number, quite a lot of paramedics now, just to run the hospital, the pre-hospital care service around in Kuala Lumpur. So they dedicated for that, and that's quite good because they are focused to do pre-hospital care. They are not attached to the hospital and get involved in hospital care. Right. So the ambulances can be placed outside the hospital now, right, where they can be put in the hotspot areas that identified the MACC. They have one emergency physician who is a pre-hospital care specialist, the EMS physician, who is on call to cover this Klang Valley ambulance service. So if they need any information, any treatment advice, it will be handled by this emergency physician. So let's go how the Klang Valley ambulance system works. If they're collecting data now, they're looking into some of the quality indicators. And if this works, then probably it will be expanded to other parts of the nation. So again, if there's an incident in the country or there's incident site, the 999 call will be called by the public into the telecom center. Again, the telecom center will divert the call to the nearest Malaysian Emergency Coordinating Center, the MACC, which is part of the Klang Valley Ambulance Service. Now, this Klang Valley ambulance service team, now they have the right to bypass the nearest hospital and send to the most appropriate hospital. For example, as I said, in Malaysia, we do not have many neurosurgical centers, right? So if this patient needs a thinks that the paramedic thinks that this patient needs a neurosurgical treatment, this patient will be diverted and trauma bypass to the nearest operate center, for example, neurosurgical center. But to make that decision, they have to discuss with the emergency physician on call for that medical directions. Our paramedics also give IV tranexamic acid to the trauma patients, general trauma patients, and those patients with head injury. They've set up a couple of KPIs for that, and the response time is one of them, and giving tranexamic acid was also one of it. The pusher for having the Klang Valley Ambulance Service was when the auditors of the country audited the pre-hospital care service. 85% of the time we do not manage to reach the response time of the P1 cases, which is the severe cases, within 9 minutes as stipulated. So it's a very sad state. So at least they start to move to establish the Klang Valley Ambulance Service, which have more leeway, more access, more ambulances, and more paramedics. At the moment, the limiting factor for this Klang Valley Ambulance Service is the lack of ambulances. Our ambulances are sometimes very old. They go to many places. They are overworked, right? And they do break down. So when they do break down, it's very difficult to get replacements. The ambulances are something that is not very cheap. Okay. So that covers the pre-hospital, the hospital care, because the hospital care, I think, is no different from most of the hospital care that you've heard before. We do have a lot of training for our pre-hospital care team, either in trauma or in emergency care. And not only we have the trauma education for the EMS, but we also have the trauma care for the rest of the people in the hospital. We have a monthly online trauma series. We have a cadaveric workshop. We have trauma. We have EMS simulations that we do. We have courses, and then we also have our trauma registry. Before 2022, we did not have our trauma registry, so we were involved very closely with the Pan-Asian Trauma Outcome Study and that became our registry to look in the trauma cases over Malaysia. In 1920, we developed our own Malaysian trauma registry that would look into the severe injuries that comes over to the emergency departments. This education and this registry become an integral part and a very important part of the whole having a trauma system in the country. We do not have designated trauma centers. We don't have a level 1, level 2, level 3. We just have what we know is the hospital capable to manage trauma, the hospital capable to do spine surgery, the hospital capable to do neurosurgery. We know that network, so we send the patient to the appropriate areas. And then the trauma registry can look into the movement of the patient throughout the whole system. And with that, I'd like to announce some of the conferences that we have. We have our second Malaysia Trauma Conference. Please come over. This will be the 2nd to the 4th of October. We have a cadaveric workshop, right? That will be, which you can learn how to do emergent thoracotomy, cricotydotomy, and all the other invasive resuscitation. We have the Malaysian Trauma Acrobatic Conference, 4th to 6th June. We will invite Professor Shin over to Kuala Lumpur because we would like to sign an MOU between the Malaysian Trauma Registry and the PATOS CRN so that we can collaborate and share data together, because we have stopped sending data to PATOS, so we can now use the Malaysian Trauma Registry data for the PATOS. And then for the last conference that I'd like to talk about, we have our MAS conference. It's not here, which is our emergency medicine conference. We will be on the 5th to 6th of June. So that's another conference that you all can, not very far away. It took me only 1.5 hours from Kuala Lumpur to Ho Chi Minh City. I'm sure Bangkok is close, Indonesia is close. Singapore is also closer, yeah, just across the border. Okay. But to put all these systems together, right? The pre-hospital injury prevention, pre-hospital, hospital care, rehabilitation, research, audit, registry. You need to have all the various stakeholders together, not only the emergency physicians. We might be the carer in Malaysia, carer of trauma care, right? But we need all the stakeholders, not only the various disciplines of surgery, radiology, ENT, ophthalmology, rehabilitation, but we also need the Ministry of Health to be involved, because the Ministry of Health hospitals are the one involved in managing trauma care. So they need to be involved in putting up a viable trauma care system in the country. And in this blueprint, we also mentioned to come up with the levels of trauma care in the hospital. We had this blueprint pre-COVID, but I think because of the COVID, this had been put aside, and I'm not quite sure when this Malaysian trauma care blueprint will be accepted by the Ministry of Health. Of course, there are many challenges for our trauma system in the countries. There are many challenges. I just divided into 3 areas. There's resource constraint and funding issues. Of course, money is always an option, and ambulance is not easy. Setting up a system probably will be probably a more efficient way of doing things, but you still need resources to pay for your paramedics, to pay for your equipments, and to pay for your ambulances. So therefore, if we focus on prevention, as mentioned earlier, prevention is always better than cure. It's so much cheaper to put an advertisement on television, to put an advertisement on the billboard for injury prevention, rather than to treat a patient with chest injury, head injury, pelvic injury, and that will take thousands and thousands of dollars. Integration of trauma care with a broader healthcare system, taking trauma as a disease, as I said before, be part of the whole trauma and public health system in our country, rather than this belongs to hospital, this belongs to private health. To break down the silos between the public health side and the hospital side, that has to be broken down. Of course, buy-in by the various stakeholders involved in efficient trauma care. Everybody needs to buy in. Everybody needs to believe that we should have an efficient trauma system in the country. Only then we can have a good trauma system in the country. With that, ladies and gentlemen, come on.
Thank you very much, Professor Sabarias. I would like to introduce next speaker from South Korea, and in the topic trauma care system of South Korea, Dr. Min Woo Kim. He is a doctor from Seoul National University Hospital. Please welcome Dr. Min Woo Kim.
Hello everyone, this is Min Woo Kim from Seoul National University Hospital in South Korea. And I'm emergency physician and now working on inter-hospital transport system in Seoul National University Hospital. Thank you for giving me opportunity to present in this symposium. So today I'm presenting the trauma care system of Korea, actually focusing on the program run in the capital city of Korea, Seoul. So these are the key contents of the presentation. Pre-hospital assessments of trauma by EMS personnel in Korea, and Golden Time Hospital Program, which covers severe diseases in Seoul, and severe trauma final treatment centers, which cover the severe trauma patients, and Seoul Mobile ICU program for interhospital transfers. Before the start, I have to explain about the Korea. The area of the South Korea is about 100,000 square kilometers, and the population is about 50 million people living in South Korea. On the Korea incidence, in Korea, incidence of mortality due to trauma is about 50.9 in 100,000 people, and it's much higher in the age of 40s and 50s. Sorry. So I'm gonna talk about the pre-hospital EMS system. In Korea, the EMS is run by a fire agency, and the type of EMS is similar as Anglo-American models. And EMS personnel are mostly consist of EMTs and usually provide basic supports for trauma patients. And there is 119 emergency procedure protocols for EMS personnel, which is regularly updated. And it contains the process of severe trauma recognition. It is almost same as the field trauma scheme in United States. Physiological signs, physical exam, mechanism of trauma, and patient factors will be considered to recognize the severe trauma in the field. And EMS always write down the EMS run sheet for every dispatch to record the information of the event. And in case of severe trauma, additionally, in-depth registry for severe trauma should be written. So you can see on the right side of the slide, this is the form of severe trauma. Oh, sorry. So this is the form of severe trauma in-depth registry, and EMS personnel fill this form with tablet PC during the dispatch. And so the EMS personnel should fill the form which contains timeline of the dispatch. And intention of the mechanism of the trauma, patient state, the final assessment of the severe trauma, and the procedure performed in the field, and hospital transfer information. And this is in the red box. This is the severity assessing part of the registry. As I mentioned, it contains physiological signs, physical exams, and mechanism of trauma and patient factors. And with this information, EMS personnel judge whether the patient has severe trauma or not, and write down the decision on the registry. And in this procedure protocol, there are chapters for trauma and injury, and they consist of several types of injuries such as multiple trauma, altered mentality after trauma, head trauma, spine injury, thoracic injury, abdomen pelvic injury, genitourinary injury, limb injury, ophthalmologic injury, dental injury, and environmental emergencies. Each chapter contains a clinical feature of the trauma, particular assessments for the trauma nature, and emergency procedure protocols, and specific caution for the cases, and indication for direct medical direction. And finally, hospital selection of the patient. The procedure protocol also contains procedures for the A trauma patient, it contains immobilization and splint supply, bleeding control, and dressing for the patients. So actually, pre-hospital emergency procedure is quite simplified, and there is not much procedure performed in the field for the EMS. So now I'm gonna talking about the hospital selection. In Seoul, there is program named Golden Time Emergency Department program run by Seoul Metropolitan Government, which 26 hospitals in Seoul participate in. These hospitals are supposed to provide treatment on 4 types of severe diseases. They are cardiac arrest, cardiovascular disease, neurovascular disease, and severe trauma. So we recommend that EMS transfer severe patient to the nearest Golden Time ED as soon as possible, and severe trauma patients are also recommended to be transferred to the Golden Time Hospital. And most treatment usually performed in the Golden Time EDs. So these are the distribution of the 26 hospitals in Seoul, capital city of Korea. And in this program, we also provide education for the EMS personnel about proper assessment of trauma patients, recognition of severe trauma cases, and on-scene treatment. And as I mentioned, EMS personnel judge whether the patient has severe injury or not. So among the patients with injury severity score 16 or higher, 58.9% of the patient was judged as severe trauma by EMS in pre-hospital level. And also we are doing education about on-scene treatment and proper hospital transfer decision. In case of severe trauma, Seoul has another program to deliver the definitive care to the severe trauma patients, which named Severe Trauma Final Treatment Centers. I'm gonna talk about Seoul, more about that. Population of Seoul is about 9.6 million in 2020, which is 20% of the total population of South Korea. But there is only one designated level 1 trauma center in Seoul, National Medical Center. So it seems it is hardly covered all the severe trauma cases in all over the city. So Seoul Metropolitan Government also made a program named Severe Trauma Final Treatment Center. So among the 26 hospitals, 3 more hospitals were selected to be final treatment center for severe trauma. So totally 4 hospitals work as trauma center for definitive care in Seoul. And this program supports the hospital to hire the trauma surgeons. So these hospitals can make the trauma surgeon team for their own hospital. And this program starts substantially from November 2020. In case of severe trauma patient, the patient initially transferred to the nearby Golden Time hospitals, and initial treatment and stabilization is performed. If the patient can provide definitive care for the patients, if the initial hospital can be provide definitive care for the patients can be treated in the initial hospital. But if not, because of the personnel, device, or ICU beds, a patient can be transferred to one of the 4 final treatment centers. And they can provide definitive care with specialties such as general surgery, neurosurgery, thoracic surgery, orthopedics, and intervention medicine, etc. So I try to analyze the effect of the program. I try to compare before and after the program. Using the National Emergency Department Information System Database, which named NEDIS, which monitor every ED visit of the Korea. So patients, patients that ED with trauma were selected who are 15 years old and older with mechanism of traffic accidents, fall, stroke, penetration, or machinery injuries. And to figure out the outcome of the final treatment, ED visit which ended up with transfer were excluded. The outcome would be mortality of the trauma patient, but as Dr. Satta mentioned, we cannot compare mortality rate directly because the severity of the patient can vary according to the hospitals or years. So I tried to calculate double score for the hospital mortality. So these are the eligible cases. In Seoul, there are about 150,000 of cases. And in 4 severe trauma final centers, 10 to 18,000 of cases every year. This shows the graph for the percentage of the patients with injury severity score 16 or over, which is calculated by ICD-10 diagnostic code. And after the program, it's around 2020, it seems that the severe cases going steeply higher in final centers. So it means the severe cases gather to the 4 trauma centers. And I compare the double score for mortality. It can be calculated as shown down there. It means the number of the unexpected survivor per 100 patients. So, and the expected survivor can be calculated using TRIS. So TRIS can be calculated. TRIS means actually the probability of survivor, so which is calculated with the equation below. So if the double score is higher, the survivor rate is higher even after severity adjustment. So this is the equation for the TRIS calculation. And I use the equation and coefficient according to the NTDB 2010. And ISS were substituted by EMR ISS. So the probability of survivor calculated by TRIS are shown in the graph. In the red line. In the red line in 4 trauma centers, after the program, right after the line, probability of survivor is steeply decreasing, which means the severity of the patient is increasing in these hospitals. And also means the severe cases are gathering to the trauma centers after the program. So after that, I compare the double score, the final outcome. Double score is increasing in 4 centers after the program. But unfortunately, the overall score in Seoul did not so increased. And unfortunately, the overall score in Seoul did not so increase. So but we are planning to continuously follow the outcome. And there remains a question: how can we transfer the severe trauma patient from initial Golden Time Hospital to the final treatment center safely? So I'm gonna explain about the Seoul Mobile Intensive Care Unit, which is inter-hospital transfer system in metropolitan area. About 9 years ago, inter-hospital transfer system for metropolitan area of Korea was created, which is named Seoul Mobile ICU. In case that the patient did critical care and is unstable, but there is no ICU in that hospital. Originally, there was no way to transfer the patient to other hospital by regular ambulances. But after the implementation of the program, the specialized ambulance for the critical care with an emergency physician, a nurse, and an EMT can safely transfer the unstable patient between the hospitals. So in case that the severe trauma patient should be transferred to the final treatment center, this SMICU provides safe and seamless transfer of the patient. So this is the picture of the ambulance, and there's quite large space in the ambulance. So we can do various procedure in the car. Recently, we the SMICU transferred 100 the case of severe trauma patient to the final treatment center. And this shows the group chat room used to activate the severe trauma patient transfer. In case of severe trauma, SMICU is sometimes asked to arrange the final treatment hospital. So by communicating among the SMICU physician and 4 centers, prompt decision for inter-hospital transfer is made. And in the SMICU vehicle, there are several devices for severe trauma patients, including critical care monitoring system, portable ultrasound, and long backboard or cervical collar and scoop stretchers for immobilization of the patient, and the rapid infusion system for RBC transfusion for the patient. And this is additional slide that I originally did not put it in the slides. So there's a helicopter transport protocol cooperated by SMICU and Fire Agency of Korea. And this protocol is for a long-way inter-hospital transfer of the critical patients, mostly from outside of the metropolitan area into hospital into Seoul. So SMICU teams and EMS get on the helicopter from Seoul and move to another region to pick up the patient and transfer the patient to the Seoul safely. So this is me getting out of the helicopter. So this is the final slide. In Korea, EMS has a written form of pre-hospital procedure protocol and transfer protocol. And to provide definitive care for the severe trauma, a final trauma center of severe trauma can be the choice. And there's special ambulance team named SMICU and can provide safe transfer to the severe trauma patient. So this is the end of my presentation. Thank you.
Yeah, thank you very much for your presentation. Next topic, I would like to invite Dr. Nguyễn Vinh Anh, Dr. Department of Emergency Medicine, Charai Hospital, lecturer, Department of Emergency and Critical Care Medicine, University Pharmacy and Medicine, Ho Chi Minh City. Yes, please.
Good afternoon, everyone, and I'm very thank you. It's such an honor for me to be here today to talk about the trauma care in Vietnam. I'm a little bit sorry at first because there's a kind of a misunderstanding about the subject of this presentation, that you're talking about the trauma system, and I'm just talking about the trauma care. But however, I will integrate the information of the trauma care system during my presentation. So you all know that we kind of a low and a middle income country, and trauma is such a huge burden. We already said this morning. But how about the trauma? The trauma care system here is just the same, because pre-hospital care, the care in the ED part, and the trauma care. I mean the trauma surgery care, the trauma ICU care. However, the rehabilitation care and the psychiatric care is still is a thing that I really want to emphasize in this speech. Also, I'm talking about a little bit from the for the vulnerable population, and also the data registry, data audit, and also for the trauma training. Sorry. So for the first aid and the initial treatment, mostly provided by the lay rescuer, especially for the rural and mountain areas. Instead, the kind of the EMS in the rural provinces is fully equipped. I mean that, and to call for the ambulance to go out there is much takes a longer time for the lay rescuer to bring the patient to the hospital by themselves. And so the first aid may be not fully not appropriate, and in some cases would be harmful. However, once they get into the district and the provincial hospital, they would be get a better care, the better care. However, besides the Bạch Mai Hospital, Việt Đức Hospital, and also some hospital in Ho Chi Minh City, in the most of emergency department in Vietnam, just about the general practitioners only, with different levels of trauma care training, or maybe not at all. So the doctors that specialize in trauma care, in resuscitation, also just located in the major central healthcare centers. And that is a huge gap between the rural area, the trauma care in the rural area in the first golden 6 hours, and the later phase of the trauma. So here's a real image. The real image is very heartbreaking also, very heartbreaking. This is a patient that Chợ Rẫy, the emergency department of Chợ Rẫy Hospital received at the sixth hour after the major trauma. She is transferred directly by the lay rescuer. The problem is that the family patient already called the 115 system at that province, but then the 115 province the team suggests that she should be admitted to the nearest hospital. The family don't accept that idea. So as the require of the family, the patient be transferred directly 6 hours without any pain control medicine, just the fluid, a lot of fluid. And you know, a lot of fluid means bad consequences. We all know that. So for the acute care quality, we have some of the survey made by the JICA from the 2008 for up to now, and the most is, and I have been searching for but recently I don't have, I cannot find. There's not much information of a survey or data about the acute care quality. So we have two private, the EMS and the non-EMS. It means for here, we call EMS. It means that just all things that related to the 115 system, and the other side is the private ambulances, the private or maybe the public transport can be used as a mean to transfer the patient. On a survey in 2005 on the military hospital 103 in north region of our country, 91% were transported by the bystanders, and 3% of them were self-transported, and just only nearly 5% of them by the EMS. And therefore, 63 of them were admitted within the first 6 hours only. And some of them, 8% of them were admitted after 72 hours. Then, however, the number is not improved yet. In 2008, just 4% of the trauma patients were transported by the ambulance. And the most significant thing here is that 42 of the RTI victims died before reaching a healthcare facility, compared with 29% in the hospital. So that we need a survey on the acute care quality and how to improve that. The nearest the latest data from Việt Đức Hospital, which is also in the PATOS registry. For now, in 2021, there's a lot of improvement. They receive first aid in a health facility for 96%, and 98% all of them was transferred by the ambulance. And they also receive during the transfer all of the procedures needed, such as the catheter, airway management, cervical immobilization, and bleeding control in approximately 40% of cases. However, the emergency surgery rate is 42%, with the ED mortality rate is 24%, which is a very concerning number. So for the traumatic, our hospital cardiac arrest, and it's just only 0.9% of them survive with a good neurological function. And this is the thing that we consider a lot of improvement in the future. And all of the traumatic OSCA witnessed by the bystander is 31%, and all of them almost all of them have a CPR taken by the bystander. However, only 26 of them was taken by the EMS, and for the rest, they are died on scene because they're waiting too long for an EMS, or maybe the harmful intervention that given by the late rescuer. So from the data from the emergency department of Chợ Hospital from the period of 2022 and 2023, we have identified the 6 scenario, the most frequently scenario for the cardiac arrest that on arrival. It means that you just enter the ED and they have a cardiac arrest. So first of all, the uncontrolled bleeding. Just like that patient have an unsecure airway, tension, pneumothorax that have transferred for 2 or 3 hours without the decompression, a critical brain injury, the massive crystalline resuscitation, and also we have a lot of cases of deadly hyperkalemia because of crush syndrome that without any support during the long transfer time. So about say something about the trauma care system here. That first of all, we don't have a strict system distribution as in your presentation. Actually, I feel overwhelmed and so amazed by the the very wonderful trauma care system in your country. The decision to admit it to the hospital or not is based totally on the family. And some of them, the patient is so critical that the family want to transfer them as soon as possible to the farthest hospital, but they think that it would be trustful, for example, for Chợ Hospital, so that they don't receive the emergency procedures or emergency stabilization during the golden hour. So when they arrive in Chợ Hospital, they miss the golden hour and they all turn into the massive resuscitation with crystalloid and the refractory traumatic shock. So, and from our data, we have the pre-hospital fluid in 66% of all cases, and with a median of 1 liter of crystalloids. And however, in 42% of cases, the volume of fluid is not retrievable. And the fluid volume in the first 24 hours, 15% of them receive more than 5 liters of crystalloid. So according to the data from PATOS 2022, that for the the data in the PATOS is just included only the public EMS transported trauma patient, not from the private one or maybe the lay rescuer one. So here the data from general ED, we included all kind of the trauma patient admitted to the ED. So how about what happened inside the ED is for you, for Malaysia, for Korea, for Thailand, you have a trauma team, I suppose. You have a trauma team and a resuscitation team. The difference here is that if the trauma patient arrive in the provincial ED, the surgeons will be kind of from various specialties, maybe from GI, maybe from neurosurgery. No one be trained in trauma surgery only. And for the central hospital ED, it's just the emergency physicians. Just about 1/3 of them will be specialized training in trauma care. So because of that, the surgeons are from various specialties. They resuscitate the patient by the surgery principle, not by the critical care or not with the critical mindset. So that leads to a lot of consequences on complications on trauma patients. The trauma surgery is another aspect that I'm concerned that trauma surgeons would be from multiple on-call doctors at that night, but no one will be take the lead that to decide that to operate or not, and they would be transfer from specialty to specialties separately to take care of different injuries. And because of that, for the damage control surgery, we don't have up to now we don't have a protocol or any principle for the damage control surgery. They take the surgery for the in the acute phase of trauma just ordinary surgery. So data from the General Hospital 2020, the polytrauma or the traumatic shock have the immediate surgery, but lasts more than 4 hours in the median. Some of them will take 6 to 8 hours to repair in the acute phase of a trauma. But the decision is that all of the surgeons want to repair almost every injury in the first time, in one time. So that makes a very long time, and the impact of the second hit will be hugely, will be very such a predisposing factors for the patient to multi-organ dysfunctional syndrome, maybe. And for the rehabilitation here, we just according to the WHO report, just 2% of our trauma patients can have an access to the rehabilitation program, and this is decreased the capacity of the patient to return to the normal life and for the normal activity. And this is the post-trauma part that we should focus on. And we have a lot of vulnerable population in the trauma, especially here is the elderly. From the Vic Hospital, 19% of the severe trauma patients is over 60 years old and have a higher mortality rate compared to other trauma patients. Especially suicide is our second leading cause of death in this trauma, elderly trauma. And that means that our physical care and the mental care should be matched together to prevent kind of a prevention for this vulnerable population. They also a report in a survey in 2022 that say that name some of the barrier for the for the elderly with trauma patient come to the ED for cost barriers. Second is we saw few geriatricians, and for the trauma patient, the treatment of the elderly trauma patient is not a holistic way. So the surgeon will treat the injury, then the medical they treat on the comorbidities, but then not geriatricians to cover all of them, especially for the mental care. So that leads to the very low quality of life, both for the physical and mental health issue and the recovery to the normal daily function. And this is more significant in the vulnerable groups such as unemployed, living in the rural or the mountain area, and someone with a lot of comorbidities and not covered by the health insurance. So we need a better, we here in Vietnam, we need a better understanding of the degree of impairment, not how many trauma patients that we can save their life, but also how many trauma patients that we can save their functional life, which would be a major idea to improve our health system. So this is a way to effort. And one, beside the trauma training, which is we are lacking of the trauma training, one thing that can be deduced from the PATOS report in 2023, you can see that you can see that there's the number of the trauma patient from Vietnam is more than 13,000. However, the actual number of trauma patients from Vietnam can join the study is just 600, which is less than all. It is a list from between the four countries. So, and with a very high mortality also. So what I can say that from this part is that, and the missing data is accounted for more than 9,000 patients. So that we really need a trauma data collection and audit also. Just like our colleague from Korea has provided a kind of a data registry, the data for the trauma information collection that can be accessed for every time that we make a survey or every time we make an audit. So, and it can be have a kind of freely access to every doctor of every health personnel, so that we can improve our understanding and improve our kind of build the motivation to really run and practice the trauma care. That's what I want to say. A good audit will lead to improvement. So thank you very much.
Okay, thank you very much for nice presentations. So we have a couple of minutes for the discussion before the break. And at the floor, did you have any questions or comment from we have five speakers, 5 countries on the floor. Did you have any question?
Việc là mấy đứa dịch lại nghe. Cái đợt này em mình đi là mình có mời cấp cứu 115 với Sở Y tế tham gia không em? Tại vì sao tất cả những cái chiến lược mà để mà dự thảo ra các cái vấn đề mà liên quan cho đến cái hệ thống cấp cứu chấn thương cũng như cấp cứu ngoại viện đó hiện nay thì là bên 115 và bên Sở Y tế sẽ là người chấp bút. Cho nên là nếu như mà nghe được những cái này để làm chi, để cải thiện về chất lượng của hệ thống cấp cứu thì nó tốt hơn. Thì hiện nay là mình nói với nhau nghe vậy thôi, chứ còn để mà có thể triển khai thực hiện được thì phải có những cái người ở trong cái phần mà triển khai thực hiện. Thì trong đó thì nó có là hiện nay là có cấp cứu 115 và cái vai trò của họ ở thành phố này rất là lớn. Đợt vừa rồi thì họ tổng kết các cái việc mà họ làm là rất là nhiều. Trong đó là giảm được tất cả các cái thời gian mà để mà tiếp cận với lại những cái bệnh nhân chấn thương hoặc là những cái trường hợp mà thảm họa. Ví dụ như những cái trường hợp mà chúng ta thấy rằng cái chấn thương hàng loạt ở những cái khu vực như là cao tốc hoặc là một số các cái trường hợp mà ở những cái khu vực mà có những cái tai nạn giao thông mà hàng loạt đó, thì tất cả các hệ thống cấp cứu chấn thương cũng như kết hợp với lại quân đội đó thì chúng ta cũng đã giải phóng và cấp cứu được kịp thời. Thì cái này đáng lẽ nên có cái bên cấp cứu 115 có một cái bài kỹ hơn về cái hệ thống mà đáp ứng về EMS của Việt Nam. Chứ còn mình nói thì ngay như Chợ Rẫy hoặc là một số các cái bệnh viện lớn ở đây thì làm chúng ta là level 1 rồi, tức là những cái trung tâm cấp cứu chấn thương tuyến cuối rồi. Cho nên là cái việc mà chúng ta tổ chức thực hiện cái PATOS nó được tốt hơn thì cái đó là phải có nhiều các cái biện pháp cũng như là những cái team để cùng nhau làm cho cái chất lượng của cái hệ thống cấp cứu chấn thương của Việt Nam nó mới tốt hơn được. Bên Huy có thêm cái tham luận gì không về của Việt Nam á?
Thank you for your comment from the Professor Thảo. Today, I invite most of Sai Province and Hospital in Ho Chi Minh City and Province Hospital Health Center from Ho Chi Minh City and 115 Center. But today, when I have the signature from the participant only to the 115 Center. Yeah, and it's the purpose of PATOS, and this time, the first time in Vietnam. We can want to connect so many not only level 1 hospital, 115 center and another district hospital, most often private hospital. Yeah, I only invite all of you come here because I want to improve the bystander and pre-hospital care. So it's dependent on the first step. Yeah, when you want to build up and want to improve your our trauma care system. Yeah, thank you, Professor Pat.
Okay, and any comment, Dr. Shin? Okay. Okay. So we don't have a time now, so it's time for the break. Thank you very much for your all. See you next session.
Before the break, we invite Dr. Parinya Thanwatbun, Dr. Min Woo Kim, and Dr. Win Min and go on to the stage to receive the certificate from host. Please. Welcome to the stage, Dr. Phạm Thị Ngọc Thảo and Dr. Satya Riyapan. Ladies and gentlemen, before going to the section for building the Vietnam's trauma care system and clinical research network, we have a 20-minute break. Okay, you can break and get back here at 30:40. Yeah, thank you.
Okay, okay, sure. Have this one. I have this one as well. Okay. Excuse me, everyone. Just to get 5 minutes to summarize that in the morning we can do the BBM challenge, use the background math with X-ray advanced. So I will show you who is the best performance. You will get a prize. Okay, the best performance is Dr. Trung. Yeah. This is a summary from the data that we collect that I want you to do the background math. Okay.
Dạ vâng, hồi sáng đó là chúng ta có một cái challenge, cái thách thức về bóp bóng bóp thông khí ở bên ngoài ấy ạ. Thì trên đây là cái kết quả về những cái thông số mà ghi nhận lại, và đây là cái kết quả tốt nhất từ bác sĩ Dương ở bệnh viện Tân Phú ạ. Xin mời cho một tràng pháo tay dành cho bác sĩ Dương ạ. Xin mời bác sĩ Huy ạ. Dạ dạ. Dạ dạ.
Under 1 billion Vietnam đồng. Yeah, the value of price is under 1 billion Vietnam đồng.
Thank you, Dr. Hiền. Xin cái file tiếp theo ạ. Xin cái like tiếp theo. BBM gọi là cái BBM gọi là cái việc và cái kết quả tiếp theo sẽ là cái FT mà CPR.
So this one is a CPR challenge. I will show you some data. Even everyone perform, we can zoom and make to read the result like this.
Mỗi lần ép tim, mỗi người mà ép tim á, thì chúng ta có những cái dữ liệu ghi nhận giống như là ở trên màn hình ạ.
Okay, this is summarized of the everyone, single one, we can track for the performance of the compression, depth, and recoil. So this is a summarize of each individual, the single of the nominate to challenge. This is the winner.
Và đây là cái dữ liệu ghi nhận lại cái người chiến thắng, đó là bác sĩ Nhân ạ. Ở bệnh viện Thống Nhất, xin dành một tràng pháo tay cho bác sĩ Nhân ạ. Dạ. Và xin mời dạ Dr. Sata.
Yeah, Dr. Sata. So you can see her chest compression fraction is 94%, average rate is 110.
Dạ
Yeah,
vâng.
this is the summarize of the data. That is how good that she did. Okay, thank you so much for your time.
Dạ. Cảm ơn tất cả các quý bác sĩ ạ. Và các dữ liệu đã được ghi nhận và chúng ta thấy là bác sĩ Nhân đã có một cái kết quả CPR rất là tuyệt vời, lên đến 94% so với các tiêu chuẩn của AHA 2020 ạ. Một lần nữa xin quý vị dành một tràng pháo tay cho hai bác sĩ chiến thắng của chúng ta là bác sĩ Nhân và bác sĩ Dương ạ. Xin cảm ơn.
Dr. Yang is the EM doctor of Thong Nhat Hospital, and her duty so many cases got reference coming. So this is has a good skill is downstream. Yeah.
And now we will continue with section 4, the building the Vietnam Trauma Care System and Clinical Research Network. We would like to invite Dr. Brian McNally and Dr. Shandu Sin to moderate the section.
Hello.
Hello.
Hello. Okay. So now we are starting for section 4. The title is Building the Vietnam Trauma Care System and the Clinical Research Network. I'm very honored to get the chance for moderating together with Dr. Brian McNally, my old friend. And I will introduce first the speaker and then followed by the next speaker by Brian McNally. And then we will have some panel discussion, inviting the experts from the Vietnam and the other countries. The first speaker is the Le Bao Huy. Yeah, he is, as you know, that he is a very important person in the PATOS, Vietnam principal investigator. And then he is hosting this conference today. And then he will talk about the recommendations on building up the Vietnam, the trauma care system. So welcome, Dr. Le.
Yeah. Good afternoon, ladies and gentlemen. Yeah. I'm really appreciated up to now for a long time from this morning. So many participants still stay here to follow our topic. And my topic is how to build up the Vietnam trauma care system. And for this morning, you heard about so many information, so many opinion about the trauma care system from another country, also in Vietnam. And we had some information from the Level 1 Trauma Center or Level 1 Hospital to another, from the very high or advanced trauma care system, from the lecture from the Professor Brian or from the Singapore or Korea. And also some situations like Vietnam, for example, Malaysia and Thailand. And in our country, we had the area 30,000 kilometers square, look like the Malaysia. And we had the large population with around, up to now, I think it's 100 million people. And this got the fourth in Asia and the 54 in the world. And as you know, we had the mechanical moving of the population to move the urban. So the urban population rapid increase and rapid quickly. And if we have the large population and increase in our rapid quickly, rapid increase in the population, we have the challenge we have to face with the risk increasing the risk of in the children and in the elderly patient. They have easy to damage from the trauma, injury, or violent or drowning. And we have some information from the report of the lecture from the Dr. Vinh Anh, Dr. Lê Phước Đại. And in Vietnam, traffic accident and drowning remain the leading causes the mortality or death in Vietnam. Every day we have the information, we have around every day 3,600 injury victims and around 90 cases of death. And most of them are road traffic injury. The road traffic injury is the leading cause of death among those aged between the 15 to 29 years. It's the young people. And how about the structure of healthcare facility in Vietnam, as you see in the picture? Most of facility are hospital to focus in the urban and in the north. In the Mekong Delta and in the Ho Chi Minh City or South Province is the later than Yan Quang Hospital. Hanoi, the capital, is expected for this is the last share on the bit foundation to improvement. So we need to give more sharing this resource. And we have the 4 levels in public hospital. It's the central level. Under the Ministry of Health, we have around 50 hospitals. And the provincial level in around 400 hospitals. And district level is around 700 hospitals. And the 4th is the community level. Besides our public healthcare service, we have the private hospital. It's around 200 private hospitals. And day by day, we have the more and more important role in the healthcare service in the Vietnam. But mostly, they located or the focus in the urban. So we have the most of facility, most of hospital to focus in urban. And the near or the another area had the less the equipment, had the human resource. For the trauma care center, for every big city, we have only one or two center. And the level 2, we have in the level 1 hospital for the central or local, and the level 3 or level 4, they also be in the level 2 hospital of province and or district hospital. So we have here the information, the picture of the traumatic or the deaths in Vietnam caused by the trauma. We know we have the lack of specialized trauma hospital and level 1 trauma care. And for example, at the topic of the Professor Sabaria from Malaysia, they had the plan to move the coordinated center and pre-hospital to beat the victims from the center to the hospital, dedicated care. But in Vietnam, most of patients, not of victims, look like the report of the Dr. Vinh Anh. They want to move to transfer to the level 1 center because they think they have so many equipment, so many good doctors look like the report of Dr. Dai. And what the problem? The level 1, so we see many patients, many victims, but not severe level, so severe severity. So they overload, but they cannot supply the fulfill or the correct or appropriate for most of the victims. And how about EMS? Up to now in Ho Chi Minh City, up to now in Vietnam, the 115 centers, so many more and more to build up satellite. For example, in Ho Chi Minh City, from the 3 satellite 115 center, up to now we have the 41 satellite. So in this data from the PATOS 2017, we received the most of, in my data, my hospital, we received the most of case come to ER by non-EMS. It's at least 98%. But up to now, it's a subchance. We have at least 20% up to now. It's a big change. And another resource. For example, you know, for the who staying there, we need one ambulance for the area with 1,000 inhabitants. But in Ho Chi Minh City or in Hanoi, the biggest hospital, the biggest city in Vietnam, we only less than 0.5. We look for, they look at another city in Asia or Asian. In the South, 1.2. In the Tokyo, the 1.8. And in Taiwan, 2.9. Singapore, 0.8. It's a higher, more and more higher for Vietnam. In the setting when the expert team to come to our ER for this lot, we have the 12 ambulance, but in the public hospital, they have a responsibility so many missions, not only beat the patient, not only for medical service. And as you know, the components of the trauma system are the forest at the another report. It's the 5 bystander care to provide the early first aid for the patient with the heart to see the scent of the victim at the scent. And up to now, who responsibility for this? They have no, because some school or the Red Cross to give some training for this, and pre-hospital EMF care to stabilize vital sign, vital function before they bring the victim to hospital. But it's a have no program, training program for standardized most of things. And only based on the 115, the public center or private 115. So we have not yet standardized. And the hospital definitive care is also. Most of victims want to move to level 1, level 2 hospital, level 1 to trauma center. And some hospital, they have no received the victim and to depend to send the severe victim to the higher level. And how about the rehabilitations? In Vietnam, we lack of the rehabilitation for the patient. In the patient come to an or inpatient, it's the same. It's the same. After operation, the patient have no advice, have no receive rehabilitation in hospital, most of case. And how we can return, how we can to send, how we can to help the patient to come to into the society and come back their work. So very important. I think also the government has some change in policy, but as the Professor Thảo told me that most of definitely care hospital, level 1 or level 2 center, trauma center, yeah, only use, cannot solve most of things. We need to pay attention more and more with the importance of pre-hospital care. And pre-hospital care needs to be the simply component of the trauma care trends of survival. For the prevention in this survival chain in trauma, you know, we have the not called coordinator center, trauma center, to run, to solve, to guide, to direct most of activity. And not only one component, we need to combination, to coordination, to collaboration, and we need to think the patient become the center of our care, especially in the trauma system. If you think that, you can change your mind, you can you can give some more and more solution, and you can call the cooperation from the most of the human resource. If you have the ethical, you have the legal, you have the finance, and you have the technology. Using, for example, for PI, for example, telemedicine, for example. But how to use most of the resource. And if you have the data, you have the data, big data for this trauma care system, we cannot useful to to solve the problem, to develop the program to solve entire problem. And as you know, the trauma education is not the standardized. From the academy, from the society, they have the different. Yeah. At that time, we need to work together. And if we work together, we put a strong voice, strong teams, and strong strengths. For the nation trauma care system, the role of the leader. Most of us EM doctor stay here. We are the practical, like the Dr. Dai said that. But there are so many things we need to run the leadership. I told the Professor Thảo that I and our colleagues, our staff, we practice every day. But if you want to train in the government, we need the nation level leadership from the Ministry of Health, from the medical university, for example. And we need to use the resource from the military leadership and the sector leadership. And how about the nation level leadership? They need to establish the nation trauma care system, and it may answer the development of common the best practice. We can collect, we can have the business data standardized, we have the resource, and work for across the continuum of trauma care. We have the convent, governmental, youth academy, and private sector. We ensure appropriate funding and the reduction of regulatory barrier. And also, we have the strategically community to value the nation trauma care system. And how about the military leadership? It's for a long time in Vietnam, it's a system had abundant resources and a personal equipment and budget. And they had the system will respond quickly and regularly training. And in Vietnam, we have the traditional, the opinion, a close military and civilian relationship. And if we have the cooperation between the military and civilian, it's useful for research, infrastructure, and training. And how about the civilian sector leadership? There are no coordinating center for emergency care trauma, including hospital, in-hospital and post-acute care. So many crowded, so many confused. When you receive a call from the 115 satellite to call my ED, receive or not? We have enough time to discuss more and more because so many patients wait at time. If we have not communicated clearly this information to call the health sector and the hard penalty in the fall. And they need to authority and accountability to civilian trauma care capability is the program and vary by local location lead to the patchwork of the trauma care system. So standardization and continuous training for trauma care is not synchronized as you already talked. So we need to suit including coordination between the government in the provincial and local health sector and academy from the university, medical university, and the expert, and private sector partner. We should attract care from the SEN to acute care, rehabilitation and post-acute care, and we need help to design nature locus of responsibility, and it should build up the trauma moderator center and developing and implement the guideline for the lower level to follow up and guide them which patient who can move level 1, level 2, level 3, for example. And we know the human resource equipment or most often can supply it. So if we have the good relationship between the civilian trauma system and military trauma system, we share the infrastructure, system design, data, best practice, and personal. and the last. If your heart, the more something moves smoothly, but you have the center to use the data and use it for the develop or improvement the healthcare service in the trauma care system. Conclusion, I think we built up a trauma care system in Vietnam. Up to now, still challenges, but it in processing and integration. And very important, the role of leadership. Then trauma care coordinator, coordination center under the supervising and direction of government can optimizing resources, building a big data system, training and coaching, and promoting international cooperation. Thank you.
Dr. Le, thank you very much for your presentation. We will have some discussion after the one more speaker lecture, and then could you go to your seat, and then next, please.
Yeah. Next speaker is Dr. Hung. He's going to talk about how to build up an EMS-based trauma registry. He needs no introduction. He's famous.
Good afternoon. Thank you for introduction. I am Dr. Hong from Seoul National University Hospital, Seoul, South Korea. I will introduce how to build a EMS-based trauma registry based on experiences in South Korea. This is not updated files. Yes, this is an updated version of my slides. Okay, I should spend time with the PowerPoint slides now. Okay, thank you. First of all, I'll briefly introduce Korean emergency medical system for trauma care. So we have only one EMS agency across Korea under National Fire Agency government body, and we have single dispatch number for 119 for fire, rescue, and EMS. Our EMS model is a public model by charge of free, and it is financially supported by tax government budget. And we are fixed ambulance operation, and our scope of EMT for trauma care is EMT intermediate. So our EMTs can perform advanced airway, intravenous hydration, cervical immobilization, but they cannot perform transfusion or giving some drugs or needle thoracostomy. And our EMS operation is based on BLS single-tiered model, and partially two-tiered model is operated for out-of-hospital cardiac arrest and severe trauma. And almost in South Korea, we have 16 provinces, so usually one dispatch center for each province cover all EMS calls for trauma, out-of-hospital cardiac arrest, and many disease conditions. This is trauma case volume in South Korea. Annually in South Korea, about 1.7 to 2 million cases visited ED due to trauma. Among them, 50,000 to 70,000 cases are EMS assessed severe trauma cases. And patients with the injury severity score equal or higher than 16, or cardiac arrest cases around 10,000 cases. This is annual volume of severe trauma in South Korea. Trauma care system monitoring is very important to improve quality of trauma care and to improve save life due to severe trauma. So from injury prevention, pre-hospital care transport, hospital trauma care, rehabilitation. So all four chain and integration of this kind of care system is important. One key item of this trauma care system is a regional trauma center, because a regional trauma center can perform fast, intensive, focused, and specialized final definite care to severe trauma patients. And they can also perform specialized education and training course for trauma team. And they also can build a regional trauma management system. In South Korea, we designated level 1 trauma center across countries. From 2012, our Ministry of Health and Welfare designated the regional trauma center, benchmarking level of trauma center in advanced countries, like American College of Surgeons in United States or Japanese trauma centers. Now we have total 17 level 1 trauma centers across country, and we used many money. And initially, our preventable trauma death was around 50% in 1998. It means about half of mortality due to trauma was preventable, basically. After implementing this trauma center designation program, it is rapidly decreased to around 15% in 2019. During this period, we have several trauma registry in South Korea. The first one is Korean Trauma Data Bank, KTDB. It is similar with the National Trauma Data Bank in the United States or Japan Trauma Data Bank. This data bank is basically hospital-based registry. So cases who were transported to 17 regional trauma center, level 1 trauma center is enrolled in this registry. In 2021, total visiting patients for level 1 trauma centers were around 34,000 cases, and among them, cases with ISS over 16 was 8,019 cases. The National Emergency Medical Center is under Ministry of Health and Welfare, produced the annual report, and this data will be available soon. And another database is Emergency Department-based injury in-depth surveillance. This is operated by Korean Disease Control and Prevention Agency, similar body with the CDC in the United States. And 23 emergency departments across South Korea participated in this program. So KDCPA and 23 emergency departments cooperate for this surveillance. But in this surveillance, mild to severe injuries included, and this database usually focuses on injury risk factor identification and injury prevention. But these two databases produced from hospital-based manner. So how can you measure community-based quality of trauma care systems? So we needed to build up EMS-based severe trauma database, not hospital-based. We have some successful history of EMS-based registry for out-of-hospital cardiac arrest. So we merged two bodies for building EMS-based registry for cardiac arrest, National Fire Agency and Korean CDPA. So National Fire Agency Fire Department, it is a pre-hospital stakeholder. Based on this body, we can collect pre-hospital information and we can capture initial candidate for data collection using EMS launch, CPR registry, and so on. And then our Korean CDPA and our team dispatch medical reviewer to each hospital, and we can collect in-hospital data system together and merge this pre-hospital and in-hospital data together. We spent about 15 years. So initially we started this process from observational study with EMS Lancet and hospital medical record from several provinces, and we expanded to nationwide manner. And we added more intervention study and more in detailed registry, and then we can make more proficient database, and we can make more quality indicators for OHCA care from pre-hospital to in-hospital field. Based on this experience, we tried to develop EMS-based trauma registry in South Korea. This is the main concept of our registry. So this is EMS-based, so pre-hospital sector-based registry to collect information about severe trauma. So initial inclusion is a suspected severe trauma case in EMS run sheet assessed by pre-hospital EMS provider under National Fire Agency. And then we also made efforts to make collaboration between Korean Disease Control and Prevention Agency and National Fire Agency. And we recently released entire database to public for research or quality improvement or policy development. This is case enrollment criteria of EMS-based registry in South Korea. So first one is suspected severe traumatic injury. So this is basically originated from a field triage scheme in CDC from United States. So first is abnormal physiology criteria, abnormal revised trauma score. So if the patient have altered mentality, measured as VPU by IVPU method, or their systolic blood pressure is under 19 millimmercury, or their respiratory rate is under 10 or over 29, so their physiologic status is unstable, they can be enrolled within this criteria. And another one is a serious anatomy, such as chest instability, proximal extremity amputation, and so on. And third criteria is a serious injury mechanism like high-risk auto crash or observed mortality in same passenger compartment. And last one is a clinical consideration like high geriatrics or pediatrics, pregnancy, or many medications. So if the patient satisfies this field triage scheme of injured patient or EMT have some suspicion of major trauma, they can be enrolled in this database. And another category is suspected severe non-traumatic injury. So injury mechanism is poisoning, drug overdose, many suicide cases in South Korea, and asphyxia, burn, drowning could be enrolled, and also abnormal RTS could be candidate. And third category is mass casualty incident, so to collect severe trauma cases from disasters. So if 6 or more casualty is observed in a single accident, these cases are enrolled in this EMS-based severe trauma database. We have around 10 years of development period of this Korean severe trauma registry. Initially, from 2012 to 14, we started to develop a basic concept of this registry for several provinces. So we selecting some candidate of variables. We develop education course for medical reviewers, and we decided how to collect the data and how to make IRB or some collaboration with the National Fire Agency and Korean CDC. After that, for the project in 2016, we expanded to nationwide data collection system. We assessed the feasibility of this data collection in rural area, very distant area, and small hospitals, and so on. And fifth project in 2019, we started to track transport cases. So in South Korea, many cases transported due to severe trauma is transported to another hospital after initial resuscitation for higher level of trauma center for surgery or ICU care and so on. So we want to track and measure final outcome of these cases after transfer to another hospital. And then during 2020 and until now, we are maturing this database collection system, and we developing new quality indicators and so on. This is a data collection process. So initially, we extracted cases of eligibility from National Fire Agency database, and then we send medical record reviewer for in-hospital care and clinical outcome data collection. So our target hospital is level 1, 2, 3 emergency departments. In South Korea, our government designated each emergency department by 3 categories, level 1, 2, 3. And we are excluded cases transported to non-registered EDs, local outpatient clinic or small hospital and so on. We are performing 2 kinds of manner to collect in-hospital database. So first is direct visit. If annual case volume of the hospital is over 20, so many cases are transported to the hospital. We dispatch medical record reviewer to the hospital, and they collect information at the scene. But if in your case volume is very small, under 20 cases, we are performing indirect vision manner. So we collect database from fax or email or such kind of unmanned online manner. And then we are performing quality assurance process. So we are operating regularly education and training program for medical reviewers, and we are developing medical record review protocols, a monthly QA meeting, and we are performing feedback to each reviewers. This is current database collection status. For example, in 2020, total eligible patient is around 46,000 cases. Among them, suspected severe traumatic injury was 26,000, and severe trauma injury with ISS over 16 was 8,000 cases. And available information for calculating probability of survival for TRIS and W score was around 7,000 cases. We are trying to continuously develop community trauma key index. We want to compare performance of trauma care between each province. We want to also continuously track improvement or worsening of trauma care performance in each region. This is just some example of our indexes producing from EMS-based severe trauma registry. This is the number of EMS-assessed suspected severe traumatic injury. So left side province is metropolitan and urban areas, including Seoul City. And right side areas are rural area, including Jeju Island. So as you see in Seoul, around 4,000 cases are collected annually, but nearly consistent data collection is performed. But as you show in this graph in Chungbuk area, some regions show an abnormal number due to increased number of EMS provider reports. So in Chungbuk area in 2019, they have a very highly suspicion of severe trauma cases, some happening of this situation, and then we can assess the situation and make some education and QI to EMT, EMS providers in Chungbuk area. This is the proportion of patients with ISS equal or higher 16 of the suspected severe traumatic injury. Nationwide, about 20% of this database is with ISS equal or higher 16. But there, you can see there are many regional variation is observed. So in mean, the ability of EMS providers to screen for severe trauma varies by region. Well, there could be some difference of injury epidemiology or severity of trauma could be occurred. This is the proportion of the severe trauma patient admitted to ED within the region. It means if this indicator is higher, it means that region can have sufficient capacity to manage all cases occurred in the region. So for example, in Seoul City, more than 95% of severe trauma cases could be treated inside Seoul City. So Seoul can manage about 95% of severe trauma Seoul citizen, but in Chungnam area, it is decreased to 60%. So about 40% of severe trauma case in Chungnam area, in rural area, they could be transported to nearest metropolitan or urban area. So it means this area needed to make some invest to increase the quality of a trauma care system. And this indicator is the proportion of the severe trauma with the total pre-hospital time within 30 minutes. So in metropolitan or urban area in left side shows a relatively high proportion of shorter pre-hospital time. It means they can satisfy golden hour from injury to final definitive care. But the rural region shows a relatively longer time, and the total pre-hospital time or region is now increasing because this is during COVID-19 period. So during 2019 and 2020, there is some increasing of transport time. And this is the proportion of the severe trauma patient transported level 3 ED. So in South Korea, we categorized all 500 EDs to level 1, 2, 3. So level 1 is usually tertiary academic hospital, and level 2 is a relatively big general hospital, and level 3 ED is very small EDs without sufficient manpower or without sufficient trauma surgeon or ICU facilities. So our EMS protocol do not permit severe trauma patient to delivered to level 3 EDs. So basically, this should be 0%. And nationwide, this indicator is decreasing from 15% to 5%, and it is a very rare situation in Seoul metropolitan area. But in Jeonnam area, cases transported to level 3 it is around 30%. So in rural area, we also have a shortage of sufficient medical care resource for severe trauma. And this indicator is the median time from ED arrival to ED operations. Our database included traumatic injury, non-traumatic injury, so many cases. So it means every case don't need to have operation within 1 hour, but delayed hour for emergency operation is not good performance for trauma care in each hospital. Totally, our median time from ED arrival to emergency operation in our database is around 3 hours, but you can see some regional variation of this indicator. So Ulsan City has a very improving of this indicator is observed from 3 to 2 hours, but some rural areas shows increasing of this indicator. And this is W score of each province in South Korea. So W score is calculated by difference of actual survivor and predicted survivor, and calculated patients divided by this algorithm. So if W score is positive, it means actual survivor is higher than predictive survivor. So that province save more lives. So grossly, our W score of nationwide is increasing from 2015 to 2020. And for example, in Daegu area in 2020, so their W score was a negative value. It means that at that situation, they will lose many severe trauma cases. We can also compare W score of each level of ED in South Korea. So for example, we categorized our EDs to 4 groups. The first is EDs in regional trauma center, level 1 trauma center, and level 1, level 2, and level 3 ED. As you saw in regional trauma center group, our W score was positive over 3. So it means if patients are transported to regional trauma center, they have an opportunity to save life more than predicted survival. But if patients are transported to level 3 ED, they can lose lives. So we can monitor this kind of difference from each group of hospitals, and we can also track improvement of worsening of this performance within each hospital categorized group. So these are strengths of our EMS-based Korean severe trauma registry. We can make some regional representative quality indicator could be produced in this kind of trauma registry. And we can also collect comprehensive pre-hospital information. And we also now started to include secondary hospital information for transferred to the patient. And during our experience, we have relatively consistent data collection method, and we recently opened this data to public, so every researchers or policymakers can use this database to improve quality of trauma care system. But we also have some weak points. The first is that it is a rare condition in South Korea, but if patients do not use ambulance, they cannot be captured in this database. And cases visiting non-designated EDs are also excluded for this kind of EMS-based trauma registry. So as you show in Chungbuk area in 2019, if there is some difference of performance of EMS provider patient evaluation and assessment, it can make some bias of this registry. And this is a retrospective design. So if data is not collected in initial EMS run sheet or medical record, it cannot be captured well. And it also has some limitation to identify specific improvement points. And not perfect, but it is an efficient and useful database for national or regional trauma system evaluation. After developing this database, we are also performing severe trauma EMS quality improvement workshop with the National Fire Agency and Korean CDC together. So we started to this workshop from December 2021. So it hosted by National Fire Agency and Korean CDC together, and we organized this program. So based on this trauma system indicator, we give some feedback to our EMS providers, their performance, their outcome, and their weak point together. So we are trying to open this QI workshop regularly, twice per year. In summary, so we developed this community-based, EMS-based severe trauma registry with cooperated with the National Fire Agency, Korean CDC, and hospital sectors. So we started to open this data to the public. So we are including all injury mechanism, mass casualty incidents. So, and we also tried to add important variables for outcome calculation like ISS, Glasgow Outcome Scale, RTS, and so on. So we are also trying to develop new community trauma key index. We are developing index and apply it to QI EMS protocol and health policy together. So we believe that this could be national and regional representative index. We can compare prevalence process outcome between each region or each fire agency or each hospitals. For example, in our quality indicator, regional trauma center shows a significantly better performance and clinical outcome. Thank you for your attention.
Okay. So thank you very much. So now we will have some open discussion, inviting all speakers standing, please, there. And then Dr. Le is coming to the front. And then we are inviting 4 panels. And then each panels will give us some short advice for the Vietnamese trauma care system development. And then first is Taehan Kim. And the second is Ivan Chua. Please come into the place of the venue. And then the Harinya and the Savaria. And then we are talking very open about how can we develop trauma care system in Vietnam. From the speakers, they will give us some good comments, advice. In part of the each subject, Dr. Kim will give us some, how can we make a good trauma education training in Vietnam first, please. And then I would like to get some discussion from the other people if you have some another idea. Okay, please.
Okay. I thought about training recommendation in Vietnam. First, I think it's really important to review the existing curriculums and training courses that are already developed in other countries for trauma care improvement. Reviewing the core content and also the purpose of each training courses will be very important, and evaluating the effectiveness of the implementation considering the Vietnam own trauma system. And secondly, looking into the system to select the primary target for the training. The important question will be who will most need the training immediately. I think because the major trauma is very time sensitive, and also the early stage of the intervention is very important for the major trauma. The primary target will be the pre-hospital EMS providers who miss the patient in the early stage of the intervention. For example, in Korea, when we are making the trauma system and we are designating the trauma center in Korea, we had a training to pre-hospital EMS providers about how to recognize the major trauma patient, how to decide to transport the patient to the designated trauma center. So it was very difficult topic, but we did a lot of offline and online training. We made protocols and we made the EMS worksheet and also the workshops. And now our EMS provider can do the field triage of the major trauma and decide who will transport to the major trauma centers. And lastly, after that, after the training, actually analyzing their compliance to the protocol, it will be very important in terms of a performance measure. Observing that they are observing that EMS providers, observing the EMS project actually perform the pre-hospital trauma care, and their decision, whether their decision is correct, will be very important. And if not, giving a comprehensive feedback from medical director or doctors from the hospital will be very important for the quality management. Because if you don't follow up with the EMS providers, the training will just end with just the training, not actual real change of the protocol in the field application of the trauma care. And my final comment about the training is that, in my opinion, training, the team approach concept is very important in trauma care. The knowledge and the technical skills are also very important in terms of training the pre-hospital providers. But teaching them with the team approach concept will be, I think, it will be the most important, because if they are familiar with the team approach protocol, they can also provide very good trauma care, but also they can provide very good pre-hospital care of the cardiac arrest and other severe emergent disease. So I would recommend teaching the teamwork and the collaboration skill of the EMS providers. Thank you.
Okay, thank you very much. Dr. Kim provided and give us some advice, a lot of things, but we talk more focused, more briefly. The next advisor is Ivan Chua about what is the recommendation from you to develop the Vietnamese trauma care system and protocol development.
So I think the first important difference is Vietnam is actually a very big country. So importantly, I think the stakeholders need to be involved, whether it is the ministry or is it just within the city itself. So I think importantly, we need to identify the stakeholders, the people who actually make a difference, who actually have some kind of say over the kind of funding that you will get, as well as the kind of resources that you actually get be provided with. And then, of course, I think we need to take a look at the examples from across the world, what kind of systems that they have. And of course, having seen one system, you have only just seen one system, because every single system is unique and different. So I think it's important to take a lead from what other people have done and then try to adapt to your own unique characteristics within the country or even within the city itself. Protocols are all available, over the internet. So importantly, I think you have to look at what you have and then see how you can just try to adapt some of these protocols. You do not really need to reinvent the wheel, because all these things are available, but just try to adapt and see how you can help to simplify things and make it easier for the people who need to use the protocols, like the paramedics or the EMTs. That's all.
Very good. Thank you very much.
Yeah. Dr. Perry, would you like to speak a little bit about trauma quality, your advice for Vietnam?
Okay, so now I will discuss about the comment trauma quality assurance. To develop the trauma quality assurance, the first, in my opinion, is you have to set the goal for improvement or the key performance index. I'm not sure in Vietnam what is the KPI for trigger the review of case or your KPI to improve. In my hospital, I have the problem that I set the goal door to ED exits in a severe traumatic brain injury within 60 minutes. But the nearby hospital of the nearby of my hospital, they set the time different from our hospital, so we can benchmark among the hospital. So you may set the KPI the same KPI in another hospital to benchmark, and this is my hospital trauma audit form. When we analyze the form, we can't audit all of the case. This is because you may have the many trauma case that have the pitfall. So we use some trigger, just like the Dr. Satha said. In Thailand, we use the 3 score and pick up only the trauma case that did and have the probability of survival more than 75%. If this patient have probability of survival more than 75%, they should not die by this injury. So we pick up this case and use this hospital trauma audit form. We analyze the process pre-hospital care, emergency department care, operation room, trauma critical care unit, ICU, and inpatient ward, and separate the cause of death is the delay diagnosis, error in diagnosis, error in treatment, error in technique, system inadequate, and complication for death. So, and after the trauma surgeon review this case, they will invite the any department that involve this case, just like if this case error in system inadequate about the pre-hospital care. So the trauma team invites the emergency department and pre-hospital care to join the trauma audit, show only case, and discuss what is the problem and how to improve it. After that, collect the data and follow in the next month. The death rate is lower or increased. Maybe I use this technique and this method to improve my trauma care system. Okay, this is my suggestion for trauma quality assurance.
Thank you. Dr. Sabaraya, would you like to speak a little bit about your thoughts related to trauma registry research in Vietnam?
Thank you. We all know that having a trauma registry is an essential part of having a good trauma system, because the trauma registry, you collect data right from the pre-hospital care until the time the patient gets discharged from the hospital, and or even up to follow-up. So getting the data throughout the whole the spectrum. But having a trauma registry can be labor intensive also. So if you want to start looking at start your trauma registry in your country, look into the data that what you want to do. Maybe look into the data that you want to collect that's important for you to look at it now. The education, as all mentioned by previous speaker, the quality assurance, the protocol. Make it simple to start off with. Then, as you move around, as you move, then you can start adding things to your trauma registry, because people are more familiar with it. When we started our PATOS registry, if I'm not mistaken, we make it quite simple. We have more like epidemiology things that is easily captured when the patient comes to your ED. As we progress in for the next our next revision, for the revision, we added other things to the registry. So you can also do such things. Gather together and find what is it you want from the registry, and develop from there. And of course, with the data from registry, do your research and look at the quality indicators that you have set. Because just collecting a data is just collecting the fruits without eating the fruits, right? So do the research on it, look into what you want, right? And I wish you all the best of luck to start your own trauma registry. And we hope that the Vietnam Trauma Registry will link to the PATOS registry, right? So that we can still have a good Pan-Asian outcome study. Thank you.
Okay, thank you very much. And from four experts, we get some good idea about the education training, protocol development, and then quality assurance and the physical registry. So any comment from Dr. Hong? Okay.
As I think to improve clinical outcome of severe trauma, measuring quality of trauma care system is very important, and database would be the first step. So as I think PATOS could be a good baseline to start to make optimal database in Vietnam. So there are many standard variables and there are many standard data collection system. But as I think some optimization of this kind of manner is important because in South Korea, we selected EMS-based registry for severe trauma because in South Korea, our Korean citizens overuse ambulances because they are not emergency condition. They call EMS and they always use ambulance. So as we think if we capture the EMS used cases, every severe trauma will be enrolled in our system. So such kind of finding best way for Vietnam trauma care system is important. I don't have a deep understanding of Vietnam trauma care system, but if there is some difference in usage of ambulances or you have many different EMS systems, you should find what is the best way collect all severe trauma cases for Vietnamese trauma care system, as I think.
Thank you. And comment from Brian, you are living in Ho Chi Minh City for a long time, short time. Give us some comment for what is the best approach to develop the trauma care system in Ho Chi Minh City and Vietnam.
I think you've heard it already today, focusing on the basics, from bystander care to pre-hospital care, the change that's occurring with education around EMT and paramedic, that will take probably 1 decade, from today to about 10 years to develop that system. But I believe there's been a lot of thought put into how to develop that curriculum and develop a professional degree of paramedicine. I think it's different than the US, and I think it's better. So it will take time, but you'll have the right building blocks. Same with hospital-based trauma care. As you've heard today, there's not trauma surgery here as a subspecialty. This was not any different than in Thailand just 20, 25 years ago. How did it develop there? Same way. There was recognition that you had many subspecialists that took care of the patient, but no one person in charge. And over time, that position developed. And I think it will be the same here. So focusing on the basics and integrating and linking pre-hospital care with hospital care, the team approach often helps save the patient. The care they get obviously is very important, but the coordinated team approach decreases delay and allows the patient to get within that golden hour. A lot of time, we know patients sitting at one hospital that needs to be in another hospital. If that is coordinated, patients will have better outcomes. So it really is a combination of education, but also implementation and organization. So you'll see the system evolve, I think, as the standards change over time.
Okay, so any people, if you are a doctor is working in any place, could you raise your hand, doctor? Only one person? Okay, raise your hand. Yeah, okay. Down, and then nurse? Oh, no nurse. Oh, thank you. And any, yeah, thank you. And public official? Public health officials? No? And actually, this is a discussion for how can we develop, how can we build up trauma care system. The topics today is about how can we build up trauma care system in Ho Chi Minh City and each province and the country. It's a kind of designing and progress of the program. So I think one of the important thing is medical directors should be developed. Medical director is one of the director. Like we can make a drama director. We can make a film director. Like this, the system director should be developed in this country. So who is a medical doctor? Because they know the knowledge and skill about the trauma. And then they have been experienced many other countries. So medical directors should be developed. They can make a program, designing, talking, collaboration between civilian and military, the hospital, and then 115, and then community providers and first responders, and then hospital doctors. So the protocol development, education training, and quality assurance, and then research is all things should be led and then designed by the medical director. So I think the Dr. Lei is trying to develop the EMS system here, and then hopefully you can make a good team from among the participating doctors and then nurses and then paramedics and the officials to develop this medical director program, because they can make a idea together and then they can make the next progress. So today we have a lot of discussions. Dr. Lei, could you give a final comment? How can you develop the building of the trauma care system here?
Thank you, Professor Singh, for in my conclusion. I already talked my opinion. Up to now, we have so many trains like the brand for the last 10 years. We have so many trains. Yeah, in the government team, in your practice. Yeah, but still now we have to face the challenges, but we try. In the first step, we need to do how to do it. If we wait the 115 or the supply more the full field service for the pre-hospital care cannot. Yeah. So up to now, emergency, we need to combination. And EM doctor, the responsibility for the pre-hospital care too. And then we go together, we go far. I think the firstly, EM department at hospital need to go with the pre-hospital care 115. And we need to say it ourselves. We need to say it ourselves before. So we need to say, we will to say the patient with it. I think so. Thank you.
Okay, thank you, Maris. Finishing this session. Okay, thank you. Go to your seat, please.
Hello, good afternoon. My name is Young-sun Ro from South Korea. I'm research committee chair in PATOS coordination center and working at Seoul National University Hospital. This presentation is the last presentation of today's symposium. So let's go. Okay. PATOS has been collecting information on trauma patients since 2015. A total of 3 sets of data had been distributed from phase 1 to 3. And in December 2023, about 200,000 cases collected over 7 years were released. This data is a crucial essential resource for research and policymaking regarding trauma care in Asian countries. So the data collected by country shows that Korea has the highest number of cases, followed by Vietnam. The Vietnam PATOS team is collecting trauma data to improve the